in collaboration with Indian Federation of Sports Medicine, from Sideline to Spotlight, Evidence, Innovation, and Excellence in Sports Medicine. We will be starting the first lecture for the day. I request all the delegates to kindly take their seats. To begin the first session of the day, it is my pleasure to invite our esteemed chairpersons to the stage. We have with us Dr. Dobson Dominic Sir, Professor and Head of Sports Medicine at Mada Medical College and Research Institute, Chennai, and currently the President of Indian Society of Sports and Exercise Medicine. With a PhD in sports science, his contribution to the field is remarkable, including unique distinction of establishing the NMC-approved sports medicine departments across multiple medical colleges in Tamil Nadu. His expertise spans high-performance sports, anti-doping, and regenerative medicine, and he has also represented as an international badminton player. We welcome you, sir. Joining him is Dr. Siddharth Unnithan, sir, a sports medicine consultant associated with Aster MedCity and Lee Regan Clinic in Kochi. His work focuses on sports injury prevention, biomechanics, and performance enhancement. He actively contributes to Indian sport as the chairman of the Medical Committee of Kerala Football Association, a member of the AIFF Medical Committee, and consultant to multiple sporting bodies. I request both our respected chairpersons to kindly come up on stage and lead this session. I request you to, sir, take over from here.
A very good morning, everyone. So we'll begin the first session as we don't want to cause any delays. The first topic is genomics in sport, and as you know, it is the latest in reshaping the future of sports science and medicine. So it's my privilege to introduce our first speaker, Dr. Mohammad Farooq, a distinguished scientist in the field of genomics. He serves as the chief scientist at CSIR, Institute of Genomics and Integrative Biology, New Delhi, one of India's premier research institutions. Today, he will help us explore how genomic insights can potentially transform athlete screening, performance optimization, and personalized medicine in sports. Please join me in welcoming Dr. Mohammad Farooq for this exciting opening session.
Good morning, everyone. So it's a great opportunity for me to talk about genomics in sports. I think in my career when I started, it was least expected that I'll be doing like some presentation about the role of genomics in sports. And before that, before my talk, I would like to thank the organizing committee of Indian Sports and Exercise Medicine Society, and also to Dr. Khalid and the Sports Injury Center, Safdarjung Hospital. So myself, I work at Institute of Genomics and Integrative Biology. Basically, I've been trained. I'm a medical graduate. I got into genomics way back in 2006, and my learning started from studying a neurodegenerative disorder, hereditary ataxias, and slowly moving on to study other related diseases. So when I started my career, we were at the juncture that we couldn't explore the DNA at the pace that we have an opportunity now to read, and not only read, but also write the genome also. So basically, so here, what I'm trying to understand, so this is my first talk about the role of genomics in sports, and I'm curious also, and I'm a learner in this area. So generally, when we were studying the genetic disorders, I'm talking about diseases, not the traits like athletic ability. So we encountered that even for genetic disorder, rare disease as like sickle cell anemia, so not even two subjects with same mutation have an uniform and like identical outcome in the form of the phenotype. So there were, like say, other contributing factor beyond the primary defect, the sickle cell mutant. So that is what was the subject of interest and has been the subject of interest now to study the genetic background. So now everywhere you see, like to human body, if there is an exposure to anything, like say you'd consider a genetic event, a genetic defect, a germline event, how the body will tackle it. Now you have events like infections. The COVID you would have seen, like say the agent was same, the response was different among different individuals. Likewise, I also, like say we study a lot about pharmacogenomics. We give drugs, but they do not respond equally in each and every individual. The genetic factors, genetic background does play a role in how the outcome of the drug response will be. And same way, I recently heard a talk and had an opportunity to chair a session regarding surgicogenomics. That is like, there is an approach in neurodegenerative disorder field. We do this deep brain stimulus, and the outcome of DBS is also determined by the genetic factors. So likewise, I thought like maybe, okay, the same way it should work in any field that you take, when maybe sports. So basically, so like sports as an outcome of our rigorous athletes training and the environment and everything that he's exposed to, and what will be the overall outcome. So generally it was based on training. So training, you can say, like, they were like based on generalized averages. What about the precision part? So that's where our genetic field, when we study diseases, we talk about the precision medicine. So likewise, I believe that I think the same role of precisionness is there with the sports medicine, and there I think the fundamental, the core, that is our blueprint, that genome of our, the human genome is definitely a role player in deciding the overall sports outcome or athletic ability. So with that, like before I venture into all that, like say genomic ness of a person or of an athlete or a sports person. So like say these are like say several demands and the pressure on human body across the different sports field. So like in general, like say there are skill required. So there are sports which requires high skills. Then there are sports which demands a lot of power, strength, and endurance part. And these different activities put pressure on human body in different terms. Like for power, you require, I think this audience doesn't need all this introduction, but I'm trying to understand myself as well. Like say for this power sports, you so body has to, body bears the load on this isometric load while a performance by the athletes. And likewise for endurance sports, there is a lot of cardiovascular load comes in. So everything has to be shaped up and be decided. Can we decide based on some genomic intrinsic factors? That's what is the subject of interest, and this is where genomic understanding genomic architecture can help. Like say to understand, like say before delving into any particular guidance or training for any sports person, if we can understand the performance metrics based on the hidden potential. So the genomic potential, where like say we can understand that are there any factors which can help understand the amount of power a person can generate, the strength part, the endurance that he has, the muscle strength, etc. There are a lot of such nuances. And likewise, if we are subjected to all this training, what are the risks? So are there any risk for like any sort of an event that physical, the stress that can create the muscle injury and the different sort of problems? And eventually, understanding the core Then the risk structure. Can we have a recovery guided by the genomic knowledge? So there are, like, say, these are the three different cores. We think that possibly it may shape the way we deal with the sports medicine in future. And I'm saying I'm confident based on the fact that the diseases that we are studying, they are largely governed now by genomics, because now the things have changed. I would like to say that, like, the first genome that was sequenced time ago, I think 25 years ago, the cost was like $1 per base of the DNA. And in human DNA, there are 3 billion bases. So you can imagine the cost of first human genome was close to $2 to $3 billion US dollar. And now in $1,000, you can sequence all the 3 billion bases. This is what is the evolution, or the revolution has happened in the field of genomics. And now it provides us an opportunity to really understand our genomes and to get the readouts of the genomes in different, like, say, field of interest, including this sports medicine. So, like, so even in, like, say, the role of the genomics in sports, if we trace back in the history, like, the first marker that was talked about was the angiotensin converting enzyme marker. And subsequently, going further, as of, like, by a recent review by Eldos, they say that there are, like, say, almost close to 251 genomic markers which may have influence on different athletic ability, athletic performances, the risk markers, etc. And further, when we study them, like, say, out of these 251 markers, so, like, everything is just not complete clear signals, basically. So when we say the genomic signals, so it's very difficult, it's very challenging to associate genomic signal with the definite outcome, because the data is huge, the confounding factors are many, and to get the very large sample size for a research study is not achievable. And in particular, if you talk about this athletic performance, you are really talking about the elite athletes, and the number of them will not be that huge. So there are, like, say, these intrinsic issues, and based on that, we will never be able to, like, say, claim any one marker in isolation giving a particular predictivity. There is nothing of that sort. So still, this, like, say, the review which has been done recently, they states that out of these 251 so-called markers, some markers are such that they have been replicated in multiple studies in different geography and different sports. So I think based on that, there are 128 markers, like, designated for markers for endurance, markers for power, markers for strength, markers for the injury, the ligamental injury, the tendon injury, etc. So, like, so these are the, like, the core, the important genes that people have studied, and they are generally assessed while, like, dealing with the performance, or while dealing with the health of the athlete. So, like, for endurance, there is a target gene called AMPD1, that's adenosine monoamine phosphatase. Then for power, there is, like, actinin 3, that's a contributor for muscle contraction. And for strength, that is the peroxisome proliferator activating receptor G. So these are, like, say, different, like, say, one of the core important markers which are linked with the different performance potential of athletes. And so these are, like, say, the other markers for what you call the risk that they bring. Basically, like, say, I had an opportunity to work with Sports Injury Center, so where we were studying people who, the athletes, elite athletes who suffered the ACL injury, and they were, like, say, already existing knowledge. It has not been explored in India yet, the sports genomics. So sort of it was our first venture, you can say one of the first venture. And there are, like, say, as the physiology or the anatomy will dictate that for a proper strength, you will require a collagen structure, a potent collagen structure. And if there are inherent deficiencies genetically which predispose a collagen structure at the risk of the the rupture or the damage, etc., the athletes will suffer the consequences of the genetic defect. Likewise, there are like say hidden cardiac threats that we study in general while we deal with any genetic diseases as well. It is now a mandatory, like say for any genetic investigation, if it deals with certain number of genes which are called actionable. Actionable in terms of like if you can identify, then you will be able to treat them. That will be like say that has to be reported. And likewise, there are like say channelopathy genes, there are cardiomyopathy genes, which are generally prevalent among healthy people as well. And we need to know before we assess an athlete holistically. So these are like say hidden cardiac threats that we need to evaluate. And then this, after that, like I just said, like say the performance and then the risk and these pharmacogenomics. Ultimately, you are going to manage the athlete with a proper pharmacotherapy. So for pharmacotherapy also, as I said, pharmacogenomics deals with the intrinsic genetic factor that determines the drug response. So likewise, you have to know the background genetics before we institute the proper therapy. So there are like say, there are like markers which are called like say, the poor which can metabolize the drug, and based on genetics, we can classify subjects between poor metabolizer, intermediate metabolizer, or normal metabolizer, or ultra-rapid metabolizer. So likewise, there can be, based on this genetic signature, there can be different drug response outcome. So this is just like overall talking about, and consider this as a primer, and not like say to deal completely in depth for one particular subject. I'm just trying to talk in general only. So like, is that genomics everything? No, we don't think so. We need to understand like say how genomics is transcribed into RNA and finally translated into protein. And everything is controlled by different other factors, epigenetics, the environment, diet, the training for particular like say, athletes we are talking about. So a lot of factors also contribute to overall outcome, and now it is possible to really capture the multiomics profile. When we say multiomic profile, then it is like dealing with the multiple investigation that you can get out from a patient, a subject, getting from plasma, blood, the DNA, the RNA, the protein, the metabolomes, everything is possible. And holistically, if we can bring in also in the overall assessment of athlete, this is where world is also moving. There are like several consortia also been made, athlone projects, games, etc. In country like Japan and in European world, I believe. So now we need to rethink the baseline. So rather than going from the generalized average-based training to individualized genetic profiling, and also like say, like while we institute pharmacotherapy, instead of trial and error prescribing, we can go for the precision medicine-based pharmacogenomic profiling, and then the other tracking that we can possibly do. So there's one another entity that that is also there, like say, based on this limited knowledge of genomics in sports, there are like a lot of ventures out there. I don't know in India how much it's there available for general market purpose, but yes, there are like say these sort of tools are available for direct to consumer basis, but it has a lot of like implication. It cannot be, it is not recommended to institute these genomic tests just on a direct consumer basis, and it should be under supervision of the treating clinician. And so likewise, there are like say a lot of knowledge we need to gather. We need to study the sports science from genomics and omics viewpoint. And this is just like not one factor, but it's a combination. It's a concerted effect of multiple variations that ultimately decide our health, not only athletes, but any human beings. So I think we need to consider that way. And this is just like one glimpse of the, I'll just take 2 minutes and I'll just finish. So this is our just first example with Sports Injury Center. Dr. Khalid is here. He was the lead in this work. And our side, Sharumi, both they took this first study. It's a pilot study to understand whether like whatever knowledge is available, which got generated in Western world, is it transferable in Indian context or not? So we did try that, studying the risk factor, genetic risk factor for ACL injury, and we were able to identify that what were established marker for ACL injury were replicated in our study group. And we believe likewise there are a lot of other factors and that requires further study. And this is like one big knowledge base that has come up now. I'm myself part of 10,000 genome project of country, which is the unique, alone, the largest size genome project of the country, and I'm one of the PI. And this plot tells about like all the important genetic markers spread across different population of the country, and you can see the gradient. It's not like it's uniform. Like all this risk factor, all these potential genetic factors, they have a spectrum gradient, so we need to understand them. We need to study them well, and they are present. We cannot ignore them. And I think this is another topic, gene doping. We need to, as we are moving on, we need to tackle this ethically. And like we have to maintain the ethics in sports, both like supporting the science as well as the guarding the protect the athlete as well. And with that, I would like to thank the organizer, my institute and Department of Biotechnology, Dr. Deepak Joshi, Khalid, Dr. Nitin Mehta, and Dr. Sharmi Raza. Thank you so much.
Thank you, Dr. Mohammed Farooq. It was an excellent talk on sports genomics. Just wanted to, since it's a very interesting topic, we'll just explore if some audience has any questions. Sports genomics is a very, very new recent advance. Now, just from our side, we'll just ask you, what is your opinion on sports gene doping? Is there any proven evidence that it is happening already? Because WADA has put it under a suspicious list. So gene doping, is it proven in any instance at this point?
So like I think whatever I could gather, like say there are instances and there are suspicions only mostly, but the proven part cannot be like say proven per se, but what I've gathered, like say not from this field, but if we understand general our humanity, then we believe that if there exists any knowledge, people tend to incline towards that knowledge, and they try to, what you call, adopt that knowledge. And one example, I would say, just extrapolating, like the drug like Ozempic and all, right? So they, like said, this is one peptide. So likewise, this one peptide we know very well because it has been studied, but likewise there are many peptides in the market, what they call in the gray market, which has not been proven, and many people talk, even in the Western world, there are ferocious use of all these peptide molecules, and likewise, so there is a heavy suspicion on these sort of a gene therapeutics possibilities. And like say for disorder, like we deal with genetic disorder, there are gene therapies which we can tackle the gene, we can target the gene, we can upregulate gene, we can downregulate the gene. So likewise, it is possible, like given this knowledge available, all this power marker, strength marker, there are instances, possibilities exist, and based on that, I think there must be some true instance also.
One last question regarding you put the collagen markers for ACL.
Yeah.
For a sports clinician, how can you extrapolate that data if we have already existing knowledge that these markers are already present in the athlete, and the athlete is at risk of an ACL injury? How do you think that can really help a clinician?
So I said, like say we just did one pilot study, and we are like say going to increase our sample size. This was just like very small sample size, and still we were like say the results were significant, but the odds ratio, if you see, these are just like close to 1.5 or so. So we don't believe that this one marker testing will help you decide like whether that person is at risk or not. We did definitely seek genotype 600,000 marker for each athlete that were part of our study, but we didn't find any association with any other marker, any of the 600,000 markers except these 4 or 5 markers, but telling based on one singularity that this is the outcome not possible. We are trying to evolve the results with more sample size, with more advanced genetic tool that we call polygenic risk scores. And also, it's like, this is just like cross-sectional. We just sampled the subject, we identified the genotype information. We need to study them back the patient's outcome. What was the recovery time, right? So like, when did the person return to the sports, given the background of now the results that we have. So that we are studying, and I think going further, this might help.
Thank you.
Just have one question.
Yeah, ask.
So in sports medicine, we look at the preventive aspect, like how well we can prevent injuries, one of the biggest things that we look at. So have you come across anything where like certain gene traits where prevention of injuries, you could have correlated something, or do you have any experience with that?
Not, I would say, not having a direct experience, but there is a lot of potential about that. And as I said, like prevention, if you say like the cardiac risk as well, right? So these are like, say, important event. Even there was a lot of noise about this COVID vaccine-related deaths and also everything was blamed on the vaccine per se. So my lab is studying those cases as well to understand the intrinsic, the genetic factor which the person was predisposed to, whether the cardiac channelopathy, whether the genes related to cardiomyopathy were present in that subject, and that was the cause for the death. So likewise, even when we subject a person for elite sports, we need to assess these risk factors which can save the life and also the health.
Okay. Thank you.
Thank you, Dr. Bhatt. We'll move on to the next session. It's our immense pleasure to introduce the next speaker, Dr. Andrew Linde, who will be delivering a lecture on emergency medical team leadership and planning for sport. Welcome, Dr. Linde. Dr. Linde brings extensive experience in pre-hospital trauma care and medical education. He currently works as a consultant with Football Association Wales, Leeds University, and NHS Wales. His primary area of expertise lies in pitchside trauma management, and his one of most notable achievement has been the development of comprehensive medical education framework across Football Association Wales Football Pyramid, along with establishing a successful collaboration in medical training with English FA. Please join me in welcoming Dr. Andrew Linde.
How do I move it along? Just that one. Yeah. Good morning. Good morning, everybody. I'd just like to take this opportunity to welcome everybody this morning, my esteemed colleagues within the room, and I'd like to take this opportunity to thank the committee for the invitation to India for this prestigious event. Both working. I just want to cover a subject that I'm particularly passionate about, and that's leadership. I've been involved in medicine for around about 41 years. I started my career in medicine within the military, and leadership is a high-profile subject matter within the military, and it's expected of everybody. We've all got to take some responsibility at some point. And ladies and gentlemen, what I want to stress is the fact that I've listened to some wonderful lectures on biomechanics, genetics. When you see me appear with a trauma bag, you know something's gone wrong. And it can go wrong with absolutely anybody. So it could be in a lab. It could be while you've got an athlete on a treadmill. It could be in the changing rooms. It could be on an aircraft. It could be anywhere. It could be at training when you're most vulnerable. So I just want to talk about our expectations and where we currently stand within India when it comes to your expertise in pre-hospital care, particularly life and limb-threatening conditions. That's what we want. I've got two jobs. I've got a job where I work in sports medicine, and my main role is working within the NHS. I know when I'm working within the NHS, if I have a patient that's deteriorating, I call help, I get that. I get 40, 50 years of expert experience that's going to come and take the pressure off me. That's what we get in sport. We've got a chief medical officer, inappropriately dressed to be working pitch side, dealing with a scalp injury. I would assume that's not a life-threatening injury, but the gloves that he should be wearing are actually in his pocket, and he's trying to staple someone's scalp in front of a televised audience of a World Cup game with millions upon millions watching that. That's what we've got to be aware of, ladies and gentlemen. Every move you make in your careers, if you're working in sport and exercise medicine, is probably going to be on film. And if you make a mistake, I'll find you, and I'll use you on a training video. We start at the very beginning in leadership. We start with a plan. And again, the military is superb at this. We have a saying in the military, train hard, fight easy. So we create plans. Now, your plan, you should all have a medical emergency action plan. Doesn't matter where you work, doesn't matter what discipline that you're working in. And it should cover that. And that's a basic. That is a basic plan. Where you are, what site you're on, how many medical staff have you got? And here's the thing, ladies and gentlemen. When you shout help, it might be a coach that comes. It might not be a member of the medical team. It might be a gentleman who's walking past the training pitch, walking his dog. So how well prepared are you? Are you prepared to be able to do an immediate risk assessment? Can I deal with this here on my own? Can I stabilize this patient? There is so many questions that you've got to ask yourself. And unfortunately, colleagues, we tend to think it will never happen to us. And then when it does, it tends to go wrong. How many of us can honestly say that every single piece of equipment that we carry onto the pitch, the training pitch, or onto the court, everybody knows how to use? If you encounter a patient that's sustained a spinal injury, you're going to need a minimum of 6 people to extricate that patient effectively. So can your coaches, can your physios, can your therapists split the Furno device? Can they put the Furno device together? Do they know how to put the head blocks on? Do they know how to fit and size a collar? If they don't, you're going to have to do it all. Then what happens to the leadership? The leadership starts to fall apart. So part of the leadership role, ladies and gentlemen, is training your team. Pre-existing medical conditions of your staff and your players. Notice I've put staff first because we tend to forget that one. PMHs of players, yes, we've got them all the time. What about the staff that are coming with us? What about the coach driver? Is he asthmatic? Is he a type 1 diabetic? If we don't have all these options in place to manage, then something may go wrong. Access routes to sites. Numbers of first aiders. Who's going to mark the route? Who's going to meet the ambulance? And communication. I've been in so many situations where it's been a case of, is the ambulance on the way? And then someone says, I don't know. I haven't called the ambulance. Well, I thought you were calling the ambulance. So then we have this back and forth because the emergency services haven't been called. So it's about designating roles and responsibilities before you even turn up for the training camp or training or game event. This is commonly available on social media. It's commonly available on all search engines. All you've got to do is put in the FIFA Emergency Action Plan template, and you can print that off. The 4 white boxes that you can see central on the slide, those are for staff names. I've been to certain football clubs, rugby clubs, etc., where they have a similar plan. And when the staff come on duty, they write their names into that white box. So if there's an event at the training, in the gym, in the swimming pool or whatever, everybody knows what their responsibility is. So you sign your name in, and then it tells you what your task is for that day. It might be to bring the defibrillator. It might be to bring the trauma bag. It may be to manage the airway. And then the colour coding you can see on the plan, that actually correlates with the figure on the right-hand side. So everybody knows where they stand or kneel. Okay, so that's the position of the patient, and that's where we position ourselves accordingly. And we practice this regularly. And we throw in difficulties. Difficult airways is a good one that we always throw in there. And then we've got to manage that in training. So we're back to the statement that I made at the beginning. Train hard, fight easy. I've put that picture up on the right-hand side because that's my DNA. That's my background. And what I want to mention here is what I found in India. And this may sound somewhat controversial, ladies and gentlemen, is the disjoin between SEM doctors and physios. In the United Kingdom, the physios, in some cases, are finely trained, extremely well trained in emergency medicine. It's not the title that means that you're going to lead a medical team. It's the experience and expertise. And in some cases in the UK, the physiotherapist will be better in pre-hospital trauma than what the doctor will be. So we've got to actually prepare the whole team. Now, I know in India you do have sports therapists and sports rehabilitators, physiotherapists, doctors. So all that I've named previously have to do the same trauma course. They all have to meet the same standard. Because as a team doctor, as an SEM doctor, everybody will be looking at you unless you've devolved that responsibility. So we've got to be prepared. And it may be having to put your ego on one side and actually realizing that the physiotherapist is better at this than you. So you let them do it. A team leader shouldn't be involved right in the middle of it anyway, because your thinking becomes too linear. You've got to be away from the incident, watching the rest of the team do their roles and leading it and making sure that the rest of the team are effective at their roles. A detailed framework for athlete care generally means practicing how we deal with a cardiac arrest, how we deal with a life-threatening condition on a pitch, on a changing room floor, in a medical room, not in secondary care. And that means practicing. It means simulation. It means practice makes permanent. A detailed framework for medical team leadership. Who's responsible for leading the team? Who's carrying the cardiac drugs? Who's bringing the defibrillator? Has the defibrillator been checked? Are the pads in date? Are the batteries charged? 5-year shelf life of a lithium battery. When was it last changed? When was it last checked? So it's attention to detail, ladies and gentlemen. And attention to detail, if you don't do it, it will go wrong big. We can't cure the patient on the pitch in most cases, ladies and gentlemen. We tend to be focused on what's wrong with my patient. Does it really matter on a pitch if you don't know that it's a ruptured spleen, or you don't know that the patient's ruptured the liver, or you don't know if it's a hemothorax or a pneumothorax? But the basic indicators are present. So what I'm getting at here, ladies and gentlemen, is my patient has lost their radial pulse. I'm having to cannulate. I think it might be a liver injury, but I don't know. There's just some tenderness on the right-hand side. That's pretty much all you need to know. And then the plan should be, this player, this athlete, this patient needs to be in secondary care as soon as possible. So your extrication plan needs to be extremely strong and robust. Stabilize the athlete. Sometimes, ladies and gentlemen, that's the best we can achieve. And unfortunately, patients will die on us. The sudden cardiac arrest recovery rates across the globe differ significantly. Europe, we've still got some way to go. And there's some good research papers out there. But research is research, ladies and gentlemen. What this will come down to is your ability to react and your ability to recognize and treat as quickly as you possibly can. With a cardiac arrest, we're looking at 3 minutes. If there's no SEM doctor present, and the SEM doctor has to be called from somewhere, maybe you're in a hotel somewhere, and you're traveling with the team, that probably means your patient's going to die. So it might be the physio, it might be the other players that are the first responders. Who actually educates players? Who educates coaches? They should know about cardiac arrest. They should know the signs and symptoms. They should know what they look like. I'm sure some of you have seen the footage on YouTube. All you've got to put in there is stretcher failures. And there's some comic footage of players being placed on stretchers. Stretchers breaking when the players have been put on there. Stretcher buggies running the patient over on the pitch. So this is what I mean about, if you look on YouTube, it's generally not the good footage that we're seeing. It's not the positive stuff. So it's about knowing your equipment and how it goes together. Processes for putting someone on a spinal board. Processes for putting a fracture pack on. It's got to be practiced, ladies and gentlemen. We can't assume that everybody knows it. Your extrication plan, secondary care. I don't care how good you are if you're a cardiologist on a pitch. You're not going to be that good, guys. They need to be in secondary care. A cardiologist can only do so much on a pitch. They've probably got 2 hands, the brain, a defib, and some oxygen with a BVM. What that patient needs if they've had a heart attack or a sudden cardiac arrest is extrication to secondary care. And I'm not going to spend too much time dwelling on this, guys, but there's a lot of myths out there about emergency medicine care. And I think it's fair to say that most of your coaches think that heart attacks exist in athletes. We need to shatter that myth. Athletes don't have heart attacks. They have cardiac arrests. They don't have many, but there's still enough out there, and our success rates are not good. I think we all need to be better. I hope that this short lecture has stimulated some creative juices in everybody within the room. And perhaps you may now be thinking, yeah, I'm not that well prepared. I commonly hear that there's a lot of sports teams out there that don't have defibrillators. We're quite lucky in the United Kingdom that we insist on it, they're mandatory, even at community clubs, because the bulk of the incidents take place at the community clubs, because they've got masses and masses of young people playing football, rugby, basketball, hockey. So the vast majority of the cardiac arrests are taking place at community clubs. So we've ensured, certainly in Wales, that every single community club has a defibrillator, and we train everybody to use it. So what I would like you to do, ladies and gentlemen, is one take home from this lecture is this. And I want you all to ask yourself the same thing. How prepared am I? Thank you very much.
Thank you, Dr. Andrew, for an excellent lecture. This is actually a follow-up for the excellent pre-conference workshop Dr. Andrew did. And I hope all the delegates who were part of it would vouch for his expertise. Now, just one query from my side. You talked about the leadership in emergency action plan and the right person to lead the so-called EAP. You said in some places, physiotherapist or the athletic trainer may be well equipped. Can you elaborate on that? Because the systems vary, but do you really think that is a foolproof, that is the ideal system where an athletic trainer or a physical physiotherapist can be the leader for an emergency medical plan?
I feel personally that it's not about the title, it's about the individual.
It's not about the title, but what about the training process? Are they equipped to handle a non-cardiac causes of a collapse? Are they equipped to look into the environmental cause of a collapse?
We train everybody that wants to work in professional football or professional rugby has to pass the same course. And that course is hard by anybody's standards. So physios, therapists, rehabilitators will have to be able to cannulate. They'll have to be able to do a surgical airway in a medical room, and they'll have to be able to impart cardiac drugs into a cardiac arrest. And we have a no-nonsense approach. If you can't pass the course, you don't work in the sport.
And we have a lot of sports medicine people now coming in. So the question is, some country has manpower available, then that would be the best, honestly telling you, after having worked in medicine for 40 years. But there are places where manpower is not available. Like I think 22% of physicians in the US are Indians. So many countries, those manpower is not available, maybe you can train your paramedical. And the training of paramedicals is much better in some of the Western countries compared to our training. So I think it should be country specific, but what a doctor can do, a properly qualified, having many of them have done sports medicine, they'll do a much better job than a physiotherapist because they can overlook the whole spectrum. Physiotherapist, okay, airway kar liya usne, that is more like it than a technician work, I think. I don't know.
Can I just respond to that statement? You've got to ask yourself, how much can you do on a pitch? BLS, that saves lives, ladies and gentlemen. Basic life support. ALS is nice in secondary care. Of course it is. Looks really good. If you're really good with a supraglottic airway, it looks really good on camera. I don't know any sports physician that's put a supraglottic airway in a player on a pitch. But I do know this. Most of them have died because they didn't have their chest pressed and a defib wasn't used.
I think since we are short on time, we'll end the session. Thank you, Dr. Andrew, for coming all the way from UK to...
Thank you.
We'll end the session with this.
I now request Dr. Kiran Kulkarni, sir, to please come up on the stage and felicitate our chairpersons and panelists. Dr. Mohammed Farooq, Dr. Andrew Lendley. It was an excellent session to start the day. A big round of applause. Thank you for the excellent session. Thank you. As we move forward into the next session, we shift our focus to an area that often goes unnoticed, yet profoundly impacts athlete injuries. Invisible injuries, mental health, burnout, and overtraining. It is my pleasure to invite our convener, Dr. Sela Ratnaike, a distinguished consultant in sports and exercise medicine from the Sports Medicine Unit at National Hospital, Kandy, Sri Lanka. We welcome you, sir. Dr. Ratnaike brings extensive expertise in injury prevention, performance enhancement, and musculoskeletal medicine, supported by prestigious fellowships from Netherlands and Singapore. He is an executive member of the National Olympic Medical Commission of Sri Lanka, President-elect of Sri Lanka Sports Medicine Association, and a recipient of multiple Best Research Awards in sports medicine. His work reflects a strong commitment to advancing athlete care, both physical and psychological domains. Joining him is an excellent panel with diverse and complementary expertise. Our first panelist, Squadron Leader Dr. Arivarsaran S. Sir. He is the sports medicine specialist at Air Force Station, Belagavi. We welcome you, sir. Dr. Shwetashri Mohanta, Senior Resident at Sports Injury Center and Official Doctor at the Paragliding World Cup 2026, with experience in both research and athlete mental health. We welcome you on stage. Ms. Angelica, sports psychologist at Sports Injury Center and a former national badminton athlete, bringing valuable insights into athlete well-being. Together, they will help us explore invisible challenges athlete faces beyond physical injuries. Please join me in welcoming the panel. Over to you, sir.
Good morning, everyone. First of all, I would like to extend my sincere thanks to the organizing committee to giving this opportunity. And I think, so we are trying to stick to our time schedule. So always it's dragging, so we'll try to finish this very important topic again with the time allocated to this particular event. So anyway, as we all know, the invisible injuries in sport is contrast to the visible injuries what we always see day-to-day life. So what matters is the invisible injuries, this component is equally or more significant, yet frequently overlooked category. One of the, the harm exists in the, in sports people. Why? I'm telling it. The invisible injuries can exist either isolate or in coexisting manner. So there's something called invisible injury continuum, which is beyond today's, the time, and we are not going to talk about those things. So invisible injuries actually included many conditions. For an example, overtraining syndrome, unexplained underperformance syndrome, and athlete burnout syndrome, female athlete triad. We all know the relative energy deficiency in sports, that's the red S, and even it included the mental conditions. But those conditions can affect profoundly not only the health, even the performance, as well as the long-term development of the athletes. So ladies and gentlemen, just to visualize some of these conditions, how it been overlapped each other. And if you really carefully see these mental health disorders in sports has its contribution to each and every conditions in varying degrees, whereas other conditions has its own overlap. So when it's come to this particular topic, I know it's a very complex topic. We are trying to, mitigate, we are trying to compile this topic into a, very shorter manner, and we have three areas to be discussed within 20 minutes, and want to give you some questions as well. So, as we all know, it's a multi-system syndrome, and it is an imbalance between the training and recovery, as well as it's combined with many other conditions. But in modern knowledge, the updated knowledge in OTS, we know all these theoretical models. But when it comes to the modern knowledge, so we come to the concept called the complex system model. So role of molecular and gut health, especially the gut microbes, and oxidative stress and redox homeostasis, transomics, network mapping, and machine learning are in part of these new concepts. But there are a lot of advantage which has been taking place in over the last 5 to 6 years. And these emerging advanced methodologies incorporating the multiple matrix enable regular monitoring, supporting both the prevention and also the treatment domains of the condition. So, with this very brief knowledge about the overtraining syndrome, I would like to throw my first question to Dr. Arivasaram. So, we know that overtraining syndrome is a condition of diagnosis of exclusion. So, how do you see this condition in contrast to the chronic fatigue syndrome? Can you just, give your idea about this?
Thank you, sir. Very good morning to you all. I first of all start with my sincere gratitude to the organizers for giving me this opportunity to contribute in this conference. I would say overtraining syndrome can be a diagnosis of exclusion. First, when the athlete is presenting with symptoms of overtraining, we first see whether it is of overreaching versus overtraining. So first we look for any functional overreaching, is it there, or after that he is presenting with supercompensation after 2 weeks. And if not, if he is reaching to non-functional overreaching. And if there is not of overreaching, then we look for his nutrition pattern, whether his sleep is okay, whether his mental well-being is okay. Ruling out all this, then we'll think about overtraining. So overtraining can be of due to any depletion of glycogen, increase in serotonin, depletion of oxidation of branch chain amino acids due to glycogen depletion. So we have to think about these things to first confirm whether it is overtraining. And thus this lands in overtraining syndrome as a diagnosis of exclusion. Coming to chronic fatigue syndrome, we cannot say directly when the individual or the athlete is presenting with symptoms of overtraining, we cannot differentiate it with duration. First, we will be working out with all the other exclusions, then we will think about overtraining syndrome. Whereas in chronic fatigue syndrome, it is the symptom which is occurring for more than prolonged 6 months. And chronic fatigue syndrome can be presenting as exertion and fatigue in day-to-day activities also, not only with sport-specific activities. So that's how we can differentiate overtraining syndrome from chronic fatigue syndrome.
Oh, excellent. Like we know, even the fatigue syndrome could be due to many reasons. Even the post-viral fatigue syndrome in athletes, which we often missed. You get the viral fever, and after that, sometimes, it's very common in this part of the region of the world, and sometimes we miss it. You correctly mentioned.
Yes, sir. Yes, it generally follows any infection, or it can be associated with any deficiencies in case of chronic fatigue syndrome.
Yeah, absolutely. So, Dr. Arvisaran, so what do you think about this, the novel method? That's the gut-brain, the axis, and also the different roles of the, the gut microbia. So how do you like trying to, explain this, in relation to the overtraining syndrome?
Sir, gut microbiota, it is a special field which has been investigated for, in more related to athlete performance. Gut-brain axis, it's a bidirectional pathway. Whether the individual is having some mental stress, the gut will respond to it, or whether the gut is not well, the mind will respond to it. So it is a bidirectional axis. So in case of gut microbiota, there are several things which are in recent research like prebiotics, postbiotics, probiotics, synbiotics, which are all correlated with athletes' performance. So the commensals we say, which is present in the gut, it is responsible for 70% of the immune function. So 70% of the immune function of the body, it is taking place in the gut. And 90% of the neurotransmitter secretions is because of the gut microbiota, for which the brain responds to it. Apart from that, we have the vagus nerve, which responds to various mental well-being. So this is microbiota, it's contributing for the mood, mental well-being, and the cognitive performance of the athlete. The common commensals which are more investigated in the recent times are lactobacillus, Veillonella species, Saccharomyces, Streptococci, etc.
So excellent. So now we know, because, I mean, it's a, like a very, thank you very much for the wonderful summary of what gut microbial roles. And we know how these things will be interrelated with the mental conditions as well, which will coming into the, a couple of minutes time. So since we have, the couple of minutes, I want to explore about the transomic methods analysis in OT. Because OTAs now, because we heard the first lecture coming from the, the genetics in sports, but in the novel context, we cannot, get out from these genes involvement in, any of conditions of the sports, as well as we are not going to talk about the immunology, but of course, it's for you a chance to, give us some idea about the genomics.
Yes, sir. Transomics are also the newest form of investigations for athletic performance, and where there are even newer methods along with the transomics are the epidemiological and the physiological and behavioral pattern analysis, forest mapping, and the artificial neural mapping. So this transomics is the study of the molecular level, where the genomes, epigenomes, transcriptomes, proteomes, and metabolomes, these are being studied at their level. So it is basically the interrelational response and the response to stress, where the one nomic method and the other level, how it responds to each other, gives phenotypes of multiple types. We say athletes who have been given a similar training will not respond equally. So it is based on that the transomic study is evolved. So based on which the theory has been given, like the transomic theory, where the epigenetic changes because of a stress, the athlete will perform differently. So the epigenetic variation will create the alteration how the bone and the muscle has to take that stress. So depending on that, the further proteomes and the metabolomes which are formed due to the transcription, then we will be able to identify whether the individual is in stress, or whether the type of stress is acute or chronic, and the behavioral pattern to the stress, and so on, sir.
So excellent. So in a small word, right? So the different athletes will respond differently for the same training load and also the environment. But that is the, the base of the transomics, and we are going to talk about. So excellent. So let's move into another area of these invisible injuries. So I just wanted to say the overtraining syndrome, whether it's been replaced or redefined, or whether it's been upgraded to the unexplained underperformance syndrome in athletes. I know that, over the last 40 to 50 years, maybe 70 years, the overtraining syndrome was well explored, and it has been still evolving. But apart from that, few of the UK scientists together, and they established this new concept called unexplained underperformance in sports or the athletes. What the argument behind this particular condition is, they question the primacy of this training and recovery concept, and they wanted to go beyond that and find what it is really. So in that context, so we were now very much concerned about this particular condition, and also in some context, we have to talk about the burnout syndrome in athletes as well. But whereas these particular conditions has its own unique features and definitions. Yeah. So what's my, the next question is from Dr. Swetsari. So in our practical terms, we talk about this overtraining. So how to distinguish this overtraining from this particular condition, that is the unexplained underperformance in athletes?
So, good morning, everyone. So, in practical aspect, when we talk about overtraining syndrome and unexplained underperformance syndrome in athletes, what we are looking upon is a systemic failure of the athlete unable to bear that load. So it's not, earlier when we were talking about overtraining syndrome, we are talking about increase in load and then giving him time to recover. But when we are talking about unexplained underperformance, we are not just looking in the gyms, we are not just looking at the training log. In fact, the training log could be very good on the paper. It's beyond the training log where the underperformance syndrome in athletes come into play. So in these athletes, the underperformance is often triggered by external factors, and it's multifactorial in most of them, sir. So for example, inadequate nutrition, poor sleep, or emotional trauma, all of them together leads to this unexplained performance. So this is how it differs from overtraining, where we are not just focusing on the load, but the individual as a whole.
Yeah. So UUPS is, I mean, as you correctly said, it's multifactorial. So you have to consider the holistic picture of the athletes, maybe his chronic diseases, all the other conditions, how he responds, his immunological status and everything. So my question for you is, how do you, take measures to detect this early? I mean, before that, one athlete's, diagnosed with UUPS. So how we approach should be, the organized in our practice as a sports physician? Or it may be even, related to coaches or the trainers as well.
So because it is unexplained, we don't have one particular biomarker that, we do this test and we know that the person is having underperformance syndrome. So in there is a Lampert submaximal load test in which you load the athlete, you give him submaximal warm-up protocol, and we see the heart rate variability, that on a normal day, if he's having a heart rate of only 80, and then while doing this test, the heart rate increases by more than 15 beats. We know that the response is different, and he's even a warm-up routine he's not able to take properly, and he's feeling heavy. The perceived exertion is more, and that is where you have to start intervening. The other thing is, more than the test, it is the subjective feeling that the athlete himself gets, that I am not able to lift that weight today. That is when you intervene, give them 48 hours of rest, think actively about clinical intervention for gut, as Dr. Arivarsan sir said. I think Angelica will talk about how psychological load can be reduced. So a team approach has to be taken in this case, and that is how we should intervene and find out beforehand, before they go into proper overtraining syndrome.
Yeah, thank you. So the mental health and disorders in athletes. So, every the bit of piece of this talk actually end up at the stress, the world stress, and also how it related to the brain itself. So as I showed you in my first picture, so the mental health and the mental disorders are, everywhere. So you cannot get rid of this particular topic. So Angelica, so how this stress as the predictor of the injury, right? How we going to what the mechanisms through which this stress actually intervene these conditions?
So, stress in general, so when we look at the athlete, they are also having real life stresses apart from having performance stress on them. So we also have to look at them as a person. And so a lot of different parameters can be there which is going to contribute in the athlete being highly stressed, such as there can be in general in their life they're going through a lot of different things. Maybe there is academic pressure, maybe there is less support from the household, and all of these things can contribute in their training sessions, like more distraction, there is less concentration while they're performing, and with that maybe they are not very concentrated or in their sessions, and that might invite new injuries for them. And then comes fear of re-injury, that is the most contributing factors for an athlete who's having history of injury. Even when they're medically cleared to play, they might compensate to protect the injured area. And that can also bring a different kind of movement or a load on the body that can result in more injuries and even severe or re-injury as well. So looking at the mental health aspect of it, there should be, whenever a load is increased during their training sessions, we should also be having a lot of psychological interventions as well. Because right after they're having any issue or a psychological barriers, that is not the only part where we should bring in psychological support. We should have it from the very beginning, even when the athlete is not struggling psychologically.
So I know like different, the psychological assessment tools has been introduced, especially for focusing the athlete stress management and the evaluation. So on top of that, like, the modern contest, this social media, okay, the peer pressure group, as well as, winning at any cost mentalities and perfectionism has tremendous issues for athletes, which has been, I don't think like many forums this will be, talk much, because you see the social media, how the athletes are being pressurized by the ordinary people as well as some of the, the organizations. So what do you think about, coping up with these particular, areas by the athletes?
So social media has a lot of negative impact on athletes as well, especially when they are injured, if we look at that. Because any time of the day they can go online on the internet and compare themselves from anybody out there who is maybe performing or having experience of years, and they have reached at that platform after a lot of their own struggles. So that is a very unfair comparison to have, but because of the exposure of social media, we can sit at home and actually compare ourselves, our chapter 2 to somebody else's chapter 20. And that can bring a lot of negative thinking patterns and a dip in the self-esteem as well. So first of all, the exposure for the athletes to the social media should be really restricted. So that's
Okay,
yeah.
so let's up to the organization to handle those parts. But of course, we know the negative impact, or psychologists or the sports doctors should raise their voice to, curtail those negative effects on athletic performance. But so before concluding, I would like to just to say this shift of prevention and management, it is the teamwork, interdisciplinary. So we know the two domains, which is lie in the health management, the health people, entire health, doctor to physiotherapist to psychologist, everything. And on the other hand is the performance by the coaches, trainers, and all these things. So it is not a one teamwork, it's an interdisciplinary. So everyone has the responsibility to trace this out. And one before, we would like to, answer any questions if you have, but we have a limited time from the audience. Yes.
So basically, we have to understand this is chronic inflammation that is going on in the body. And that chronic inflammation happens because it's a response to whatever training we are doing, and that helps us in hypertrophy or whatever in adaptations of the training. When there is chronic inflammation, that is when we are doing the training, but we are not able to recover as much. And so there is no certain time limit, that after this many months or this many days of rest, the person will be better. You have to intervene, and then it will depend differently for different athletes.
Yeah.
If I'd like to add, sir, like if it is a muscular cause, if the individual is presenting with overtraining syndrome with various muscular, maybe a strain or any tear also, so we have to give particular amount of interval of training based on the upper limb or the lower limb where the muscle strain is. Or as if it is a bony cause, then we have to wait for at least 4 to 6 weeks for bone remodeling to happen, at least not the radiological way, at least the clinically he might be improved, then maybe we can start the training gradually, sir.
Yes. Yes. So that's a very good question, Dr. Faris. So pre-assessment of, all these mental assessment tools, it's like a pre-participation medical examination.
Sir, first, during the pre-participation examination, we have to rule out the anatomical dysmorphism, yeah, any anomaly, yeah, any condition which is pertaining to provoke injuries in that particular sport. Maybe we can exclude the chances of injuries, or maybe we can modify his training accordingly if he is in a borderline anatomical abnormality or so. So we can avoid such serious injuries with the type of training, or maybe we can change the sports discipline which he might be
And
interested.
what he was really wanted to ask is different kind of scores, assessment tools for mental health conditions and all.
Assessment tools, sir.
That is, so are we in a position to use this, and the usability and also to applicability? Yeah. Yes.
The scales can be used for assessment of the individual at various levels.
So yes, so there are some mental health tools. There are IOC consensus about this. So there are mental health tools for the entourage which is not trained, and then there are for the doctors also. So they assess, and then we find out, once we find out whether that athlete has clinical depression or anxiety, and then actively work on it. We can also use, right now we have recent advances where we can do neurobiofeedback for the athletes, and then we can have those sensors. We can see that when we ask them to visualize, we can see what is their arousal level, how stressed they get when they visualize the stressful situation. And then in turn, we ask them to visualize in such a way that the fear for that starts decreasing. So we do have intervention tools for that.
Okay, thank you very much. And thank you very much for the panelists as well as the organizing committee to offer this opportunity. Thank you.
Thank you so much for the insightful session. It's easy to see something like the physical injuries are easy to see, but the invisible injuries are just as important. I would now request Dr. Siddharth Onethan sir to kindly come on the dais and felicitate our chairpersons and panelists. Dr. Asela Ratnaike. Squadron leader, Dr. Ari Varasan. A big round of applause. Dr. Shweta Shri Mohanta. Miss Angelica. Thank you so much. Please join in for a group photograph.
lead this session, we have our esteemed convener, Dr. Kenjom Sir. He serves as CMO and Commandant and heads the Sports Medicine and Sports Science Center under the Training Directorate. With vast expertise spanning sports medicine, trauma, and emergency care, along with interest in doping control and athlete development program, he brings a comprehensive perspective to athlete health and performance. Joining him is an accomplished panel of experts. Our first panelist, Squadron Leader Dr. Arivarsan Sir, is a sports medicine specialist at the Airmen Training School, Air Force Station, Belgavi. His work focuses on injury prevention during physical training and ACL rehabilitation. A gold medalist during his MD, he is also an ISAC certified anthropometrist, holds a FIFA diploma in football medicine, and has significant expertise as a ringside doctor in national boxing events. Next, we have joining us Dr. Khyati Vakharia, Senior Resident at the Sports Injury Center, MD in IOC Sports Medicine, and MD and also holds an IOC Sports Medicine degree. Team doctor for the Indian athletics team at the Asian and World Championships, a former international athlete and national champion in pole vault. She offers a unique perspective combining elite sport experience with clinical expertise. Next, we have Dr. Shushmita Kushwaha ma'am, Assistant Professor at Safdarjung Hospital and Team Doctor for the Indian National Women's Football Team. Her expertise lies in musculoskeletal interventions and sports injury management with extensive hands-on experience in elite female athlete care. We are also joined by Lieutenant Colonel Dr. Kumar Sanjay Nirala, a sports medicine specialist from the Army Institute of Physical Training, Pune, bringing valuable insights from military sports training and high-performance environments. Please join me in welcoming our convener, sir, and panelists for this insightful discussion on female athlete health.
Good morning, the August House, and welcome our esteemed panelists here. If you look at it, it's the female athlete health seems to be very simple topic. But at the same time, before I start, I would like to say now that if anybody have seen that movie Dangal, where the dialogue where Amir Khan says, ki medal to medal hove, chahe wo chhodi lave ya choda lave, right? So if you look at it, Indian women have actually been performing very well in sports. But I believe that we could have done much better, because I feel the female, not female athlete, the females have not been addressed properly. The female issues have not been addressed properly. And most of the time, most of our coaches in the country treat females like a male, smaller size male. So there are a few, an Olympic medalist once was told by a coach that, oh, you run like a female. He was commenting to a boy that you're running like a female. And she said, yes, sir, if he can run a little bit more faster, maybe he can run like a female. So starting with that, before I start the talk, we all know the major differences, but we have a very good panel here to discuss. So I have a small video. Can the video be played, please, before we start the talk? It's just a small 2-minute video. Lights. Can we off the lights? Can we off the lights? can you please switch on the lights, please? So this video, I don't know, long ago I got from somewhere. I managed to keep it, and this is what I do when I try to teach, not just my male coaches, but even the females. So this is almost self-explanatory, especially with the periods. So we all know, I mean, we're all doctors and sports scientists here, so we all know the physiological differences, around 5 to 10 very important physiological differences related to performance. But now, not taking away much time, I will start with our esteemed panelist, quadrant leader. How would you like to maybe discuss, low energy in females and address the nutrition also along with what we have seen in the video right now, the periods?
Thank you, sir. In case of low energy availability, there is reduced energy uptake, so the individual will feel just as you showed in the video. First, there is decreased production of hormones. So decreased production of estrogen will be going for menstrual abnormalities, and decreased testosterone, decreased thyroid function. So as such, district thyroid function starts, then the metabolism gets lower. Once the metabolism gets lower, the mineralization of bone gets delayed, and the formation of muscle proteins and muscle synthesis gets delayed. So once this is delayed, the athlete will go for prolonged period for getting recovered from the training. So recovery is delayed. So once the recovery is delayed, then the stress reaction starts because of overtraining. Yeah, regular training load, which is because of this delay in recovery, he will go for stress fractures or muscle strains and so on, sir.
Thank you. My next question would go to Dr. Sushmita. How do you think we should modify training, especially during pregnancy and postpartum? But before that, I'll just give a question which, an example. Recently, I had one of my top athletes who is a swimmer. She's 39. So she had a baby, again, late pregnancy. And the first thing after pregnancy was she asked, the question was how to train during the pregnancy period. And then, of course, postpartum too. And within 5 months, she won medals in the nationals, 2 to 4 medals. I think she got 2 golds, 1 silver and 1 bronze. And the first thing she called me up was, she said, sorry, sir, I couldn't break the record. She owns a couple of national records. You must be knowing her name also, Richa Mishra. So that's what I felt, how better maybe I could have helped, so she wouldn't have had to tell me, sir, I couldn't break a national record. But although this was 6 months postpartum, she was still breastfeeding. The baby was with her in the competition in the swimming pool. So she was managing that separately also. Good. So I'm just giving a background. So this is more like elite athletes, how we can help their performance.
Thank you, sir. The biggest misconception with pregnancy and postpartum that exercise should be stopped or it should be continued as usual. But the fact is, exercise and training should be continued, but it should be adapted as per the body changes. During pregnancy, there are various physiological changes, like blood volume rises, heart rate rises, BP fluctuates, center of gravity shifts, breathing mechanics changes. There are several changes. So exercise should be adjusted as per that. At this time, there should be focus on maintaining the performance and recovery, not to achieve higher goals or to increase strength. During this time, mainly strength training, for the strength training, we should focus on effort-based training. Like athlete has to train on 5 to 6 rate of perceived exertion and should engage into moderate intensity exercises only. For cardio, they can go for light walking, cycling, light jogging. These are things allowed. And most important thing is focusing on breathing mechanism, core activation, and strengthening of posterior chain. These are the major things that should be focused during pregnancy. And after delivery, that is postpartum period, first 6 weeks should be given for recovery. And during this time, light walking and breathing exercises and core activation. Only these things are allowed. After 6 weeks, strengthening exercises should be continued. But it has to kept in mind that strengthening exercises should be gradual. Load has to be given gradual. Otherwise, it will impact the female also and the baby, because the breast milk production will decrease. So we don't have to hasten the process. We don't have to overestimate the goals. It is a physiological process, and we have to go for this in a great way so that athlete can achieve a safer and stronger return to play.
Thank you so much. I know, of course, there's more depth into it, but because of shortage of time, we have to keep it a little bit short. So now I'll request Colonel Sanjay Kumar Nirala to, can you just tell us how would we differently train for strength training our female athletes?
Female athlete training required a special attention because of a special physiological and partial difference in their protocol making and during the training period. For their core principle is same goal, same methods. This should be the basic principle for male and female. Same goal, same methods. For that, in female athlete, we have to take, they have heavy weight lifting training should be important. For this, turn off length to the strength training, power, hypertrophy, and their endurance training. Principle is same. But physiological cases, in case of the female athletes, they having difference from the male athletes. Like women typically have less muscle mass due to the lower testosterone levels, but the strength gain, percentage of improvement of their are very similar to the male. This is the important things. In case of the respond to the progressive overload, they are as equal as male and female. But in case of their perform more repetition at the given percentage of 1 RM. They are the good things for the female athletes. Physiological changes we should be considered while we are prescribing exercise oblique recovery training to the female athletes. Sir. In addition to two practical analysis of their training period, first volume, they are having higher tolerance to the volume. For this, we can adjust more set and repetition. That is important. Volume, this is the intensity, can handle lower load, so higher load, so can be advised higher intensity when advised to repeat the same exercises. But frequency recovery is faster, so we can advise to train more given period of time. Their rest recovery is generally better, but for that slightly shorter recovery period is required for the female athletes. In female athletes, strength training needs a smart programming on the requirement basis, adequate volume, progressive overload, and injury-aware training program. Whatever the responsible for the injury in the female athletes, that should be addressed and should be taken care during their strength training periods.
Thank you. And so now I'm very happy to go to my next panelist, Dr. Khyati. I don't know how many of you know that she was a national record holder for pole vault. Big hand to her, please. We have, it's very nice to have a sports physician who herself has trained at a very high level. And in fact, the moment I was requested to, I was asked to convene this thing, the first thing I requested was I need a female athlete on board. And we're lucky to have her here. So, so my questions will be a little more athlete-centric and your personal experiences more, basically, rather than just going on the scientific aspects. So now we'll go back to when you were training as an athlete. So on a personal level, how were you managing, say, your issues that we face, with periods? It's like one is how are you managing your periods with training? How are you managing your dysmenorrhea if you were having it? how are you managing your menorrhagia, how are you managing breast soreness. Most people don't understand that female also have a lot of breast issues, but especially because they don't talk about it. They don't talk about it. In fact, I have a lot of my female athletes, I guide them towards the female. Now, of course, I send to Dr. Khyati. Even I send to the gynecologists also, they don't go because they don't aspire, I don't know, they don't want to share. I don't know, it's a basic problem. So I'll just tell you, India also is still a problem, especially grassroots level. When my sister got her periods for the first time, my mother, who at that, us zamane mein, kya bolte hai, double graduation for the masters, so it was such a big thing. And all she said was, "Acha, beti badi ho gayi," was her reply. So as an elder brother, actually, I had to read up everything and then guide her on this. So we understand the Indian context too. So can you please elaborate on that?
Thank you, sir, for having me on this panel. Going back in the day when I was an athlete, one thing that stands out was the athletes that I trained, all my training partners were males. So I was the only female in our entire training group. And my training was not any different than how the rest of my team trained. So there was no difference that I'm a girl, they're males. There is no training, there's no difference in the training load. Everything was the same. And back then, it was like, if I'm going to tell my coach that I don't feel that great, or I may not be able to do the workout that he's put out on the sheet today, then it makes me look weak. And what if I'm in that particular phase and there's a meet? So whether I'm in the good part of my month or bad part of my month, I still trained just as much. There was no difference in my training in the first half of my cycle versus the second half, because I usually had issues not mostly on the menstrual cycles, but like the premenstrual phase. I felt really lax, like the hormonal fluctuations, like my coordination was affected. I wouldn't, pole vault being a very power-oriented, speed-oriented sport.
Power and very technical.
Very technical, and you need that kind of coordination. So the 3 to 4 days before my menstrual cycles would start was the time which was the toughest for me. So I would always look up the calendar and see whether any of my meets are falling, on those days. And I'm lucky enough to have like a regular cycle, so I can really like plan that, okay, I need to do something way more in advance so that my meet doesn't fall on these days. So I think that was an issue. The other thing is like body image is also an issue, because how I feel in one certain part of the month, I feel completely different when I'm closer to my cycles. And sometimes when you go out in the meet, it's like, how good you feel is how good you'll perform, right? So there is a psychological aspect as well. So I think all of these aspects, but I never really differentiated, neither did my coach really differentiate my training, because say if every month during those 5 days, if I'm not going to train or if I'm not going to put in that work, God forbid the meet is on that certain day, then would I just pull out of a meet? So that's not practical. So as athletes, I think everybody just pushes themselves, and there is no rest anywhere.
Thank you. So it's very nice to see, from the athlete perspective as a doctor. So I've not come to the medical aspect. We just took the personal. I'll come to that later. Squadron leader. Now, I think there's no point in going on why females are getting more injuries. It's more like, maybe could you add on how we can prevent the ACL injuries, the stress fractures, the pelvic floor issues that they have?
Sir, most of the injuries which are happening in a female athlete is because of, first is the anatomical variation as compared to male. Females have a wider pelvis. So, and it also contributes for ACL injuries as compared to male. And second is the Q angle, which is differentiated from a male, which is also because of the wider pelvis also. And Because of a wider pelvis and the Q angle difference, the female have a tendency, literature says they have a tendency to use quadriceps more than the hamstrings for knee stability. So since we all know that the hamstrings are the agonist for the ACL, this quadriceps frequent activation is also a projected cause for increased ACL tears in female. So we should work more on hamstring strengthening also. As compared to male, we have to more focus for female, especially for hamstring strengthening. And second is the stress fracture. We all know that because of the low energy availability, hormone dysregulation, and the menstrual irregularities, this is causing the stress fractures more common in females because of the decreased bone density as compared to male. And with this, if we are not conditioning the female athlete properly before putting her into action, then there is a chance for fractures. So we need to focus more on their nutritional supplements. Maybe we have to focus on their energy availability. The calorie intake is the first one which we focus for during training. So if there is an energy decrease in spite of either in carbohydrates or proteins and fats, and then the micronutrients, which is least focus. So we have to make sure that their calcium and vitamin D supplements are regular, or if their level is low, accordingly. Then comes the pelvic floor. As compared to male, the female has the more activation of pelvic floors during high impact activities like running and jumping, even during cycling. And the pelvic floor muscles are the neglected part. Even during pregnancies, people, even gynecologists, forget to advise their patients to have their pelvic floor exercises regularly. So athletes, definitely, yes, we have to focus more on their pelvic floor exercises in align with all hamstring, quadriceps, and calf muscles.
Thank you. And my next question again is for Dr. Sushmita. Now we know with sports science, more and more athletes, before they used to retire at the age of 27, 28, 29, now more and more athletes are pushing themselves to go to even 40 if legally the laws allows. And we have a lot of world number ones at the early age. Some are making comebacks. So post-menopausal, maybe a few lines on how would you advise post-menopausal or around the perimenopausal area to train for the elite athletes?
So with the menopause, performance declines in every female athlete, and it is quite different in endurance versus strength athletes. In endurance athletes, there is biggest challenge of energy availability and thermoregulation. So for in their cases, it is seen there is with age there is decrease in aerobic efficiency, heat regulation, disturbed sleep. So it impacts their performance more than compared to strength athletes, and it is more variable depending upon the temperature also. In cases of strength athletes, there is loss of muscle mass, muscle strength, and bone density. Because of that, there is decrease in power production while strength training, and which exposes them to major injuries. So for strength and endurance, different training program has to be incorporated, but this thing has to kept in mind that it is a physiological process. So training has to be adapted as per the changing physiology.
Thank you. Colonel Sanjay, just a few lines to add to what squadron leader Aravasan has said. Basically, to add to that, a little few words on the LEA, low energy availability, and the red S in females, to add to when he talked about injuries due to training. What can you add to that?
Add on, sir?
LEA, low energy availability,
sir,
and red S.
Red on, this is the relative energy deficiency in sports. It is a syndrome caused by due to chronic energy deficient and fulfill the diet by the energy dietary intakes that support the training and the daily function of the female athletes. They affect the systemic involvement, hormonal system, metabolic system, bone health. How will we diagnose? Diagnosis based on the menstrual changes, training and diet history, and obviously medical investigation. But treatment require increased energy intake, medical and nutritional support, and recovery times. But recovery times for the energy level comeback is in weeks. Recovery type for hormone and menstrual cycle comes in the month, but recovery level of for the bone health require year, month to year. For these purposes, this is a time period we have to bond and look after the athletes. We have to give so much of time for their recovery. This is important because in the bone changes take time, minimum 1 year. But in case of the book, the bone changes of lower extremity take minimum 8 weeks. So 8 weeks should be considered anyone develop the Rett syndromes in the athlete cases.
Thank you. So now I'll just request, since, just give me 2 minutes more, just Dr. Khyati. I would like to just ask you on your personal experience, maybe when we were playing, even we were not using the hoop, but there's an app, I don't know how many people in the house know about Fitter app for women. Fitter app. So that's why. I know about it because this is what I advise my female athletes to use. Hoop and obviously you have to buy the equipment. So it's how to manage your cycle. So Dr. Khyati, I think, would be the better person to let us at least few lines on what is the Fitter app and how we can monitor. And the other, we have the Ultra Human and the Whoop, which is being used. So can you just elaborate to the house?
Yeah, so the Fitter app is, basically it has different aspects to it. So you can sync your menstrual cycle with your training. So it will give you nutritional advice, like it will track your menstrual cycles, and based on the phases that you are and the symptoms that you put in, it's going to tell you what are the nutritional changes that you could make, what are the training and exercise changes that you could make during that certain, those certain days of the month that you're not able to train at your best. So that's one of the ways for the female athletes to get feedback, and even like slight nutritional changes at certain parts of your cycle can make such a huge difference as to how you feel, and like the brain fog and like all of those things can be taken care of on the nutritional aspect. Ultra Human has come up with a ring which also tracks your menstrual cycles and the ovulation and all of those things. So it's just it's good information to have for the female athletes, but until and unless your coach does not get on board with you on that, then it becomes difficult.
Agreed.
And if the athlete feels like the athlete has to tell the coach that, look, I don't feel great during these certain days, and if the coach doesn't get it, or if the coach feels that, okay, if I'm going to do this every cycle, then she's going to mentally get conditioned to this thing that, oh, I will not be able to perform at this part of my cycle. So it's about that balance where the coach and the athlete are on board, and you find a way to, like there's a way to warm up. Like if I am feeling really great, I could warm up, say I could take 20 minutes to warm up to get to that arousal level. But if I'm not feeling great, I could do a different routine for just 10 minutes and still get to that point. So it's about finding those solutions, and these solutions are so individual for every athlete. So it's about, getting on the same page.
Okay, thank you so much.
Questions?
But just a minute before we get a question. So I will come to the questions. The first and foremost, there are a lot of questions I have for the panelists, but due to shortage of time. But what we'll do is here, I'll just summarize quickly, is the most important thing for doctors, we read up. But I think like when coaches or male, whenever I go to the ground and I see females, where are the females today? They said, sir, female problem. So female problem, nobody questions, right? They give off because heavy periods. So nobody questions what is your problem, what is your issues. As doctors, we face a lot of problems, shortage of time, we can't discuss. But I think it's very important, like she said, to educate our coaches. And most of the coaches in India, still 60 to 70% are still males. So I think ISSEM, IFSM and ISSEM should also take up, Safdarjung Sports Injury Center should take up to actually educate the females also, but the coaches more importantly. And for sports physicians, I think we need to collaborate with the gynecologist also, because to understand that most people don't know that we can use OCPs for delaying the periods, for managing the periods, especially those with dyspareunia, heavy dysmenorrhea, menorrhagia. So delaying the periods does help. We've had women athletes lose world championships and grand slams because they had very heavy periods and they didn't have the science to back them up then. So I think this is more important, to collaborate, have a holistic approach. Education, I think, is the way forward. So now, yes, your question. And please address the question to the house.
I'm Dr. Manish Pariyar, Head of Department Physiology at Dr. SN Medical College, Jodhpur, and sports physician from Patiala. What should be the fitness test for the models? Because this is also part of exercise physiology to become models. So, there are any fitness tests for models?
No, models as in you're talking about catwalk, ramp walk models.
20 years back when I was attending sports medicine, sports medcon at Jawaharlal Nehru Stadium CGO complex.
Yeah, I get it. So
the
you're
book
asking
was
about
given about fitness
models and
on
supermodels, right?
Yeah, that was.
Yeah, because even I think I have managed a lot of injuries with models and all because they need
Then
medical
please,
clearance nowadays.
You can reply or
But
anybody.
you know, you can address the fitness protocols would be the same. I mean, as you would treat them like an athlete then. So instead of running, they're walking. Anything you want to add, Dr. Sushmita? Like I do medical clearances also for some of them, especially if they're doing any international modeling assignment or if they have all those reality shows, they have to go for reality shows. I've been lucky enough that, you know, and it came through a sports physician only from Mumbai, ki please do the medical of these models. I've been fortunate to do that, but it's almost the same. It's just that, yeah, you have a look at the walk instead of running. The biomechanics of walk, I can say maybe, yes, it's good. That's where the money is.
Hello, I'm Brigadier Mukul Pant.
Yes, sir.
Consultant based at Jaipur. I have certain models with me I can discuss with you individually. But my question is slightly different. My question is, what is this fitter app? How it is to be used? Where is it available? So that I can educate my athletes as to how to approach it, where to get it.
Yeah, that's what I had requested.
So
I'd asked her to answer.
it's an app that is available. You can download it on your iPhone or on your Android. And you just have to put in your details, and the athlete starts to log in their menstrual cycles. So it'll pick that up and then kind of predict like when your next cycle is going to be, when you're going to be ovulating. And then based on how you're feeling on certain days, you can put in your symptoms saying, I feel really flat today, or I feel
So this also helps in indirectly maintaining your diary for your menstrual cycle and your hormonal cycle, so you understand the training period. Like she had said, if you're on the same page with the coach, then you can modify the training, right?
And it can give you nutritional advice as well.
Fitter, F-I-T-T-R. Yes, there's a free app also, but if you want to go deeper and into training and coaching, there's on payment also. Yes, but the basics are free. Are we okay? So, final summation by Dr. Khyati, please. As an athlete, how would you do it differently?
So, one of the main things, get your coach on board, get a team together whom you could work with, and it's okay to go slow a few days, try to find creative ways to deal with those things with every athlete, and it's very individual.
Thank you. Sorry to take little extra time.
Thank you, sir. So now we'll felicitate our speakers. So I would like to request Kenjom sir and Dr. Colonel Anup Krishan sir to kindly come on the stage to kindly felicitate our speakers. So first up we have Squadron Leader Dr. Arivarsan. He has been felicitated. So now we'll move on to Dr. Shushmita Kushwaha, ma'am. We now have Dr. Lieutenant Colonel Kumar Sanjay Nirala, sir. We now have Dr. Khyati Vakharia. And finally, our chairperson, sir, Dr. Kenjom, sir. Dr. Faris Ahmed sir, consultant in sports exercise and musculoskeletal medicine, currently leading services at Colombo South Teaching Hospital with international training from UCLH, UK, and experience as Chief Medical Officer for the Sri Lankan contingent at major international events. He brings a rich blend of clinical, academic, and team care expertise. This session promises to bridge screening, prevention, and on-field preparedness, key elements in safeguarding athlete health without further delay. Now, I invite Dr. Madhapola sir to lead this important discussion.
Shall I start to?
Requesting Dr. Andrew to please come up on the dais.
Thank you. Good morning, all. So without getting delay, we'll start the session. And first of all, I would like to give my sincere gratitude to Prof. Dobson Dominic, Barun, and ISSEM team, so inviting us all the way and giving a fantastic experience. And the organizing committee, including Dr. Upula and her team, so they have done a wonderful work. So thank you very much all. Thank you very much for inviting us. And so the sudden cardiac death. So sudden death or sudden cardiac death in young athletes. So when you have a sudden cardiac death or sudden death in young athletes, it gives highly impactful bad remark for the society. And so if you are the team doctor or if you are the doctor who is handling the emergency, next day in the newspapers and all the TV channels, your face will be there. So everyone is interested. And recently we had a one sudden cardiac death, and so it was next day it was appeared in almost all the newspapers. So it's giving enormous attention in the society. And the thing is, the people think the athletes and the people who are doing physical activity and exercise, they are the fit people. So while you are doing sports, physical activity and exercise, if you are getting some bad thing like a sudden collapse or sudden cardiac event, so it gives a bad remark for the society. So you know our region, the Southeast Asia region, so we are facing a big problem called non-communicable diseases. So diabetes is going to be the next sky-high disease in our region. So physical activity and exercise is one of the major preventive measures. So promoting physical activity and exercise is one of the major thing in SEM consultants or SEM doctors. So we have to take all the measures to prevent sudden cardiac events. And the pre-participation examination or the PPE, so we can identify risk and we can modify and we can alter their physical activity level. So there are a couple of international guidelines supporting documents and conferences. So they have laid plenty of guidelines. We just want to know. Those are we able to fit those guidelines into our kind of
area like Southeast Asian population because we are genetically different and our body structure is different. Our musculoskeletal system has different things. So we'll have a talk on that. And the key limitations in ECG, including false positive and false negative things, and cost of ECG, and doing some further investigations. So we'll talk with the panelists what is their idea. So the incidence is very much rare, even though it's very much interesting and important wherever in the world. You see, this is the recent article of British Journal of Sports Medicine, almost like 1 in 100,000, 1 in 150,000, sometimes 1 in 300,000. That is very much rare, even though. So it's very much important. So the sudden death and sudden cardiac death. Sudden cardiac death includes the sudden death. You know, more than 50% of sudden death is sudden cardiac death. But there are some other things like our part of the world. So we are hot, humid, so easily we get heat stroke, especially in military training. You know, when they had to run more than 10 miles, 15 miles, so they end up with even though we think the heat stroke is rare, but it's not that rare. So we must be missing that, okay? So the things like medication and stimulants, like testosterone, like some other, like heroin and all, some other stimulants, medication, they also may playing a bigger role. But when you see this slide, you know, even the type of cardiac deaths, different types will be different in different region and different time of the world, okay? So my first question goes to Dr. Siddharth. Siddharth, this athlete, is there any kind of physiological difference when you are training, or the things called athlete heart, which may lead to cardiac events?
Yeah, very good morning. Yeah, so definitely an athlete who is training continuously, there are definitely physiological changes, and usually I divide it into 3 parts, basically. I say that there's going to be electrical changes, structural changes, and functional changes. So electrical, as we know, you know, they'll have sinus bradycardia. Structural, he will have his hypertrophy. All chambers will be hypertrophied. And functional, you will see diastolic changes where there is increase in that. Now, one of the main critical decisions, what happens is that when this turns into a pathology, that is what we have to look for. And I still remember one of my first cases when I was starting my career, I did screening on a cricketer, and he had a cardiac issue. And so I had gone to the cardiologist, who's a top cardiologist in Kerala, and I had asked him, what is the best test to find out you know, whether this is going to turn into a pathology, whether it's an ECG, an echo, a cardiac MRI. He said a proper history. So always start with a proper history. So he says that always ask, you know, whether they have had any exertional syncope, any abnormalities. They will say, they know, because these people train on a daily basis, they know abnormalities. It's just that they are scared to tell you. But once you start poking holes, you ask questions, they will tell. History of sudden cardiac death.
What is the difference in athletic heart, you know,
one of the major differences is one, structural chambers are always hypertrophied. Okay. In pathological heart, usually you will see only a single chamber, maybe a left ventricular hypertrophy. So when we take an echo measurement, you do an echo measurement, we always assume it will up to 12 to 13, you know, that's the gray area. Okay. So that is normal. It is considered an athlete's heart. But in a pathological, when it goes beyond 15 millimeters, that is when there is a risk for sudden cardiac death.
Okay, in between 13 and
13 and 15, that is the, we would like it ideally less than 12, at least 12 we would like it, but usually we see it around 13, 15. Okay. And then we go based on guidelines, you know, whether that can cause, but if symptomatically history, he doesn't have any issue, then we take the decision. So we stratify, you know, into what characters. Then in ECG changes, you will see early repolarizations. We might see small changes, T-wave inversions, those type of changes we might see. But mainly we'll see sinus bradycardia, we see definitely LVH, we see hypertrophy, and in all cases, these are the changes what we see.
So, you know, the most common thing we face in our country, when we do pre-participation examination, when we find a silent murmur, okay? When we refer to cardiologists, so parents and everybody, the coaches, teachers, everyone come behind and say, doc, you look here, he has been running for last 1 year, we didn't have anything, right? So what is this? No, he was the team leader, and so far he has done some records, so it's really difficult to make them understand. So there are problems like, so when they are walking, when they are doing their day-to-day activities, when they are bathing, swimming, so nothing will happen. But the exertion or the competition, so might precipitate some cardiac event. So it's like this, when you have, we can differentiate into different categories. So it's something like structural cardiac abnormalities, or the electrical cardiac abnormalities, so even the acquired cardiac abnormalities, they may be having this, but when they are physically active but not doing any competition, they don't have anything. But if they're in a competition, because of the dehydration, because of the adrenaline surge, maybe electrolyte imbalance, maybe acid-base balance, something may precipitate some ventricular tachycardia or ventricular fibrillation. So, Dr. Siddha, what are the emerging pathologies as far as in your experience, what you have seen?
Earlier it was, we see the traditional one, which is our hypertrophic cardiomyopathy. But now what we see is arrhythmogenic cardiomyopathies, which was usually singled into the right ventricle. It has been now seen also left ventricle and both ventricles involvement.
That's pretty interesting, because we thought our part of the world, the hypertrophic cardiomyopathy is the commonest, most
commonest. That's the commonest.
And the arrhythmogenic right ventricular cardiomyopathy is more
quite
common in European world.
Yeah, it's more, it's comparatively rarer in our, one thing which we see is, definitely we see is myocardial fibrosis. That cardiologist recently, when I was talking to him, he said after COVID, because of viral myocarditis, they have a viral myocarditis, and then sometimes there is small myocardial fibrosis, which can cause and shift to a channelopathy. And that can cause problems, and that can reach into sudden cardiac death. They have seen in many of these gym goers who have collapsed. We read in the news, gym going and collapsed.
I think recent one, Indian famous bodybuilder.
Yeah, bodybuilders, then that could be also due to stimulants. We don't know. But this one was told when in their meetings, when they discuss about sudden cardiac deaths, they're saying that this is also one area which is emerging quite a bit, where they're seeing due to the myocarditis, viral myocarditis after post-COVID, there is small fibrosis which occurs, and that in heavy exercise, intense exercise, when it occurs, sometimes, a person who has never trained, he suddenly decides, I'm going to do 50 push-ups, and that can turn into sudden cardiac.
Okay, great.
And the arrhythmogenic myopathy is more like a cardiac tissue is replaced by a fibrous, by the fat infiltration.
So there are plenty of guidelines they made, especially American Heart Association and European Federation of Sports Medicine. They have made some guidelines and some research paper articles regarding pre-participation examination. So not only that, there's everyone in this part of the world, we refer the European Society of Cardiology guidelines when you have any cardiac issues. So they have made some guidelines. Not only that, the people who are interested in sports cardiology, they sat together in Bethesda, so they made a kind of a consensus statement regarding sports cardiology, what you should do. So the American Heart Association, initially they made 12 steps for the screening. Now, recently they have updated it up to 14. And so they have included ECG as well. So my next question is for the Dr. Faris. So Faris, the importance of history taking and clinical examination. When we were medical students time, so everyone impressed on the most important thing is taking the history and the basic clinical examination. So, and the basic ECG guidelines. What is your experience and what you can talk about that?
As we all know, that history is the most important in detecting the reason for of the pre-participation evaluation to detect to prevent any sudden condition which cause sudden cardiac death or cardiac issues. So the history, in terms of history, there are different guidelines, different ways of doing, but the American Heart Association came up with the 14-point history which you displayed, that basically was a personal history which includes the exertional syncope, chest pain or palpitations, or is there any unexplained fatigue and any sort of known murmurs, or the athletes was previously been investigated for any cardiac by a consultant or physician or something.
Unexplained syncope may be the only symptom.
Yeah.
When you go through, that's a hookup.
Yeah. So that's basic of cardiovascular symptoms related to the cardiac conditions, right? But the most important part in the history is that family history, because we know that there are conditions, as we discussed earlier, there are congenital conditions and structural and channelopathies can give rise to.
Yeah,
so it's very important to go through.
Previous lecture, so you mentioned.
It's very important to go through the history, family history, into 3 generations. So that's the most important, because family history has to be most importantly to sort of rule out
because hypertrophic cardiomyopathy, there's an autosomal dominant gene.
Exactly. So just to rule out whether there are any unexplained or sudden cardiac deaths before the age of 50 in the family members of first degree, or is there any sort of disabilities due to cardiac conditions which is existing within 50 years, or whether they have the
sedentary lifestyle, premature coronary artery disease is very much higher in our part of the world.
And also the important thing is that whether they have any the known established familial diseases like sometimes some athletes might come and say that they know that have a family history of HOCM or Brugada or long QT syndrome. So these are sort of very much known these days. So those things has to be very clearly explored in 3 generations of family history, which is very important, because we have come across. I think to very clearly say, recently, there was a history of a 2nd generation previously with a sudden cardiac death, and we went through the ECG and we just found out there was some features suggesting of an HOCM, which is about the Q waves and the symmetrical, deep T inversions. Then we did an echo to turn out to be as a young 14-year-old, turned out to be a HOCM was and we had to go for a CMR to get it. So it's very important to go into 3 histories of the family history, and then the examination. The American Heart Association have come out with an examination of at least 4 points to see whether there's a femoral pulse or blood pressure, and then murmurs, especially the murmurs, which is the ejection murmurs with the Valsalva or outflow tract, left outflow tract murmurs. So this is an American Heart Association, but we have sort of established system, as you said, discussed that we have changes in the region. So we have to have a history which is beyond that cardiac conditions. Like it should include menstrual, like we discussed, the menstrual history. And
okay, just a couple of words regarding ECG, the importance of ECG.
Yeah. So the ECG, and I think we can discuss about that further. Because ECG, the important thing is that there are different guidelines, different views in different regions. Like basically, American Heart Association, the US-based, they're not much in favor of promoting an ECG into a...
That's expensive for them.
For them, it's expensive. That's what they come out with. And they also say that about 30% could be a false positive. But the ESC guidelines, which is mostly widely we practice, which is mandate an 12-lead ECG as one. And especially 2017, we have the international criteria, which is a very good criteria, which you have displayed already. We have a very good findings for normal findings in ECG in athletes, abnormal findings, and we have a borderlines, and then based on that, how to move on that. If I am to elaborate that, shall I elaborate more on that, or is it okay?
It's okay, because time is running.
Thank you.
Thank you. And so whatever you do, the screening and examination, everything, but there are some conditions where you will miss, and you will have some unfortunate incidents on field. So, Andy, so as a sports physician, what are the things, what we must do to get the readiness, like our equipments, training, setup, what should we do to prevent unexplained or unwanted event?
Preparation is everything. Fail to prepare, prepare to fail. Prior planning prevents poor performance. In the UK, we have 48 different models of defibrillator. They all do the same thing, but operate slightly differently. So it's about the preparation. Anecdotally, I think 90% of your success as an emergency clinician is going to be in your preparation. And it's understanding that anything can happen at any time. The British Heart Foundation, the research that they've done, there's 3 main categories of those that are predisposed to cardiac arrest, and I'll just be really brief on this. 90% of men. We have a high proportion of black Afro-Caribbean athletes that are predisposed to cardiac arrest. And the other one is family history, which my colleagues have discussed to some degree. But it's about expecting the unexpected. And unfortunately, ladies and gentlemen, if we don't prepare, if we do assume that it won't happen to you, it probably will. And then it's the worst case scenario ever. Your patient, your athlete has died. And I can't think of anything worse.
So what are the commonest causes you have seen, like is it the aortic rupture or the cardiac rupture or VT or VF? So what are the commonest causes you have?
To answer that question honestly, I'm going to be really blunt here now. I'm not bothered what it is. I need to deal with it. I need to give my patient the best possible time, the best possible option. I need to press the chest quickly. I need to use a defib within 3 minutes. I need to get that patient to secondary care, to expert care in an emergency department as quickly and as efficiently as I possibly can. What I'm interested in is maintaining life support for the patient, getting them to secondary care, and then the cardiologist and all my esteemed colleagues can then tell me this was the cause. But at that moment in time, when that player, when that athlete, when that patient drops to the floor, I'm not really that concerned what it is.
What I mean, if it is a kind of an electrical issue, so next minute, if you do a chest compression or defib, they'll be right. So if it is things like aortic rupture or the dissection of aorta, so we'll be having very...
Outcomes are going to vary, obviously, bearing on the causation. What we focus on when we're educating is just making sure that everybody knows, doctors, physios, therapists, rehabilitators, that the causation is probably going to be conduction or structural. We found out later what it is. It's about dealing with that patient. Can I just give you a little bit of an anecdotal case? One of the Welsh players, a gentleman by the name of Tom Lockyer, he was screened every year. ECG, the international squad has an ECG every year and an echo every 2 years. Those are UEFA guidelines. Tom Lockyer had no family history. All his results were perfect. He collapsed on the pitch at Wembley, and the resuscitation was okay. It was okay. We found out after the event that he had Wolff-Parkinson-White syndrome. After the event, ladies and gentlemen, because the team presented to the emergency department a player that was ROSC, return of spontaneous circulation. So a win. That's really all that matters. And that's my big passion. I defer to my cardiology experts, and I ask them later.
Okay, thank you. Just to conclude the session, Faris, just a couple of words regarding debates and controversies regarding PPE.
I think we discussed in the previous question about the controversies. The controversies are mainly on as a pro-ECG and anti-ECG, like kind of. The pro-ECG is a group like most of them, the European Society of Cardiology, they promote the 12-lead ECG as because they found out that nearly more than 95% sensitivity and specificity for conditions with HOCM and long QT syndromes, which can be detected with ECG. Whereas the anti-ECG group, like American Heart Association, because they think it's very expensive for them. But I don't think, in our setup, ECG is inexpensive back in Sri Lanka or in India or subcontinental region. But in the US, they said it's expensive. So they said, there's about 30% of false positive, and also it's a distress for the athletes, as well as so based on that, the anti-ECG group is like, but from my experience, since working in UK and here, and I think we should stick to the European Society of Cardiology with appropriate history as well as 12-lead ECG, and then go beyond that one. In terms of the regional controversies, like, I mean, as the same things, like whether because the the Italian, one of the very famous review in the study was found out that having a 12-lead ECG is the sort of the best way to go for a pre-participation screening protocol. But all in all, as Andy discussed that, I mean, what I would say that for the prevention, it has to be an appropriate training, education, and then pre-participation screening, and access to AED, and at last, an appropriate emergency action program. This all has to be combined to prevent the sudden cardiac death in sports.
Okay, excellent. So we can give some space, couple of minutes for one or two questions from the audience. Yes, sir.
If you look at the practical ground reality, there are hardly any pre-screening procedures done in schools. Probably when the athletes are somewhere around, see, people are thinking of training for national levels are going to be trained somewhere around a 6th or 7th or 8th class, maybe 10th class. They are picked up. That is where the initial, first SCD, they are missed. If you could do them or early in the college, because WPW could have been probably picked up in an ECG. Why it was not, I don't know. Maybe there was no change initially. It's a little surprise. Or it was missed by a person who did not really know how to read an ECG. Because ECG reading, there are a lot of gray areas, unfortunately, and many times not reported by a cardiologist.
Yes, thank you very much. That's an excellent view. Really, our education or the teaching curriculum, we must include the basic life support, because the most of even fair number of healthcare staff, they don't know how to do basic life support. So it's a pathetic thing. And yes, sure.
What's the UEFA guideline for the match, the referee? I'm under the impression that the fourth referee is a referee for the AD. So what's the knowledge on that one?
Controversial question. Current guidelines for referees and players when it comes to education is non-existent. We don't educate players, we don't educate referees. We have a potentially catastrophic situation where a referee officially has to grant permission for the clinician to run on the pitch. So we'll have a referee that may have seen a player collapse, that may see them, quote unquote, be moving, hypoxic seizure, tonic posturing, whatever. And the referee might say, no, leave them, they're still moving. They've not actually recognized signs and symptoms of a cardiac arrest. And the medical team are waiting to come on. So we have got a long way to go in Europe in educating players and referees. And generally, guys, players are the first responders, but we're not getting to the players, we're not getting to the referees.
When we talk about medical cover, basically, we all know in competitions there is some kind of cover. Even in the ISL, you have proper ambulances. The screening is done properly. I think Auja sir is also there. We've worked with the somehow or the other something is covered. But that question which
Okay, sir. Thank you very much. And thank you very much, Indian Society of Sports and Exercise Medicine and Indian Federation of Sports Medicine, giving the opportunity to Sri Lanka Sports Medicine Association. Currently, we are having MOU and we are working together to share the knowledge and everything. So thank you very much, panelists, expert panelists, Andy, Siddharth, and Faris. Thank you.
Thank you so much. Now I would like to request Professor Dr. Dobson Dominic sir to kindly come on the stage, and we can have a group photograph as all our panelists have already been felicitated. I would like to request all our guest panelists to kindly come on stage.
Can we please have the lights on the stage? We now move on to the session that beautifully bridges preventive medicine and athletic performance, lifestyle medicine and performance enhancement in sports. In an era where longevity, metabolic health, and performance intersect, this discussion becomes highly relevant not just for athletes, but for all of us involved in sports medicine. It is my pleasure to introduce our convener, Dr. Lakshmi Sundar ma'am, lifestyle medicine physician and head of Department Preventive Foot Care at Dr. Ramachandran's Diabetes Hospital. She currently serves as the president of the Indian Society of Lifestyle Medicine and is actively involved in the World Lifestyle Medicine Organization. With pioneering work in diabetes reversal program, she contributes to research in food biomechanics, initiatives in lifestyle medicine education. She brings a unique and impactful perspective to this field. She herself is also a marathon runner, and we invite you, ma'am, on the dais. We have an exceptional panel joining her. Firstly, Colonel Dr. Anup Krishan sir, Director and Professor, D.Y. Patil University, Navi Mumbai, with over 25 years of experience spanning elite sports medicine, military medicine, and high-performance science. His contributions as a team physician, international dope control officer, and former consultant at the highest level of governance in India makes him a leading authority in athlete performance optimization. We welcome you, sir. We invite Dr. Hanjabam Barun Sharma sir, a key figure in sports and exercise physiology, currently associated with IMS Banaras Hindu University as the founding leader of the Indian Society of Sports and Exercise Medicine. His work in physiological and performance medicine continues to shape academic and clinical practice in this domain. We welcome you, sir. Dr. Sanjay Kumar Patil sir from AIMS Kalyani, whose expertise spans neurophysiology, metabolism, and exercise physiology. With extensive teaching experience, multiple research projects, and significant academic contribution, he adds a strong scientific foundation to this discussion. This session promises valuable insights into how lifestyle interventions can help not only in disease prevention, but also athletic performance. I think we have one more. I also take this opportunity to invite Dr. Sanjay Sood sir from the Indian Federation of Sports Medicine. I'm sorry, sir. Dr. Sood sir is the former Chief Medical Officer of the Super Speciality Block at Safdarjung Hospital and currently serves as the Joint Secretary General of the Indian Federation of Sports Medicine. He is also a member of the IMA Central Council and the Indian Association of Sports Medicine, reflecting his active role in shaping healthcare and sports medicine policies in the country. His areas of expertise span lifestyle medicine, preventive cardiology, cardiac rehabilitation, nutrition, sports medicine, and disease prevention, making his work highly relevant in today's shift towards holistic and preventive healthcare. I request ma'am to take over.
Good morning, everybody. This lifestyle medicine, part and parcel of every specialty, and I'm glad that we're having a panel on this. I'm slightly changing the context here. We are not going to talk only about competitive athletes, because a large chunk of your practice would also include the mushrooming recreational athletes that you see. That includes me as well. A major chunk of your practice with, events, masters, and, so many running events happening, and I'm just out of a High Rocks event from yesterday. So events like that happening, I'm sure you're going to see more and more recreational people as well. Okay. So when you say you're an athlete, you're expected to be healthy, you're supposed to be, having a good metabolic health, etc., etc., etc. But we are increasingly seeing a lot of headlines and papers which talk about people collapsing in the gym, people collapsing towards the end of a marathon. Every event you see a couple of deaths in this country. So why is that so? Are we looking only at one angle of exercise and forgetting everything else? Is there something fundamentally wrong? I think there was a panel on sudden cardiac death, so paucity of time. I'm not going to talk about sudden cardiac deaths here. So when I say lifestyle medicine, where does that fit in? It is just not an adjunct to training. Let's get that very clear. It is the biology for performance. If your athlete has to perform, every aspect of the lifestyle should be perfect. It's just not looking at one pillar. In lifestyle medicine, we talk about 6 pillars, which I would be addressing one at a time. When we look at performance, we talk about coaches, we talk about athletes, talk about apparel, they talk about shoes, they talk about supplements, and the increasing number of supplements that you see in the market these days. They talk about doing no pain, no gain, intense workouts, new equipments, popular coaches. These are all the priority that an athlete gives. What we fail to look at? We look at pre-participation screening, as you talked about, basic blood work, basic ECG. We forget to look at their kitchen, their bedroom, mental health. We forget to look at all those aspects. A good health begins in your kitchen and your bedroom. So what is this lifestyle medicine that I'm talking about? It's an evidence-based practice. We are all board certified allopathic doctors. We help individuals and communities with comprehensive lifestyle changes. What we do, we address 6 pillars like nutrition, exercise, stress management, social communications, your substance abuse, etc., etc., and sleep. We help prevent, manage, and even reverse progression of non-communicable diseases. But we overall, what do we look at? We don't look at the sickness model of care. We look at the wellness model of care, right? So we want to prevent sickness. So the entire model of care is on wellness and not sickness. So when I talk about the pillars, here I'm just setting the context. What is it? Nutrition. You expect your athletes to be absolutely with perfect health. If you see, there are papers that say 85 to 100% of the athletes suffer some form of nutritional deficiencies. I see this even amongst recreational athletes. Being a coach for recreational runners, I see that very often. Iron, D3, commonest deficient, protein deficient diets, very poor eating habits. There could be many reasons: the necessity to maintain their weight, maintain a particular physique, which is necessary for their sport. No proper nutritional guidance. That never seems to form a part of their management. And relative energy deficiency. This is not just true for female. Red S exists for men as well. And this is a paper that was published comparing Psi athletes with a tribal population, and they found that both populations showed deficiency in iron, vitamin D3, and many other micronutrients. The second pillar, sleep. How many of you in this room sleep well? Yes, yes, yes. I see a very minority of the hands going up. Most of you are not. That includes me as well. I've just slept for 1 hour this morning after an event because I had to take a flight and come here. So 38.5 to 59% of the athletes across various disciplines experience very poor sleep. The reasons could be many. The reasons could be a competition anxiety. The reason could be exercise overload, smartphone usage, no proper education on sleep hygiene, basically. Many, many reasons, because we don't give so much of an importance to sleep. When a person walks into our clinic, how many of us question about sleep? We never give importance. And we've always said, associated ourselves, when somebody sleeps a lot, we have labels for them, right? Traditionally, we've had labels for them. Exercise, yes, we are all talking about exercise here, but do we have a common pattern across, do we have coaches having similar guidelines? When you see in different cities, even amongst athletes, there is no proper fundamental knowledge of how to give an exercise to your athlete. I see them doing too much many times. There's always an exercise overload. And no one focuses on recovery. Even Dr. Kyati was talking about rest. We never speak about rest amongst athletes, which should be an important part of it. Stress is very common. Mental health, I think, is never addressed. Performance anxiety, high societal expectations, comparing with their peers. Financial insecurity, especially amongst young athletes. We see them, I have to go back and earn for my family. I cannot focus on the sport that I am committed to. And fear of failure. There are other reasons for poor mental health, but when we're talking about athletes, these seem to be the commonest reasons. Substance abuse, India ranks high when it comes to substance abuse. Not just substance abuse, we'll talk about with the panelists, experts, we will talk more on this topic. And we never focus on social connections. Social connections are fundamental, how you communicate with your coach, how your relationship exists with your peers or the surrounding community that you're living in makes or breaks a good athlete. So social connections are very fundamental. When we talk about lifestyle medicine in general, we focus a lot on social connections. Social isolation, isolation is the worst punishment you could give anyone. And we've seen communities that are isolated, you have more incidence of cancers and some metabolic health issues. So social connections have to be very important. When you make a good athlete, you need to have a good connections with their coaches and the peers. With this background, I'm not paucity of time. We're moving on to the questions. We'll start with nutrition. Protein, protein, protein. This is what we hear everywhere. Okay? Everywhere that we talk about, we see protein. Protein in everything, literally. Protein in your rotis, protein in your breads, protein in your... People consume protein bars. Yesterday at the High Rocks event, I saw every athlete walking around with, tons and tons of protein bars, which is just sugar at the end of the day. And they were like fueling themselves with protein bars. And, can you, Dr. Sood?
I'm Dr. Sanjay Sood. Actually, proteins is the most important issue. It is a very overhyped, commercially driven. Normally, if you know what to eat, you know how to eat right. you can get all the protein you want without, in fact, without supplements. But commercial interests make the things hype, and then the coaches and the players, they go overboard these protein issues. See, the most important issue to understand with proteins is they are not for the energy purposes. They should be used for the purpose they are supposed to be used. Otherwise, because they are generally expensive. Anything which provides protein is more expensive than the carbohydrate load, and that is why the majority of the Indian diet is more overloaded towards carbohydrate. And many of the poor students, when they come, poor athletes, when they come from homes where carbohydrate and fat was much more emphasized. And now they are actually coached into they require more proteins, and that is how the story revolves. But the most important thing to understand is how to eat the right protein. See, protein have amino acids as the building blocks. There are 20 amino acids. But the most important thing to understand is 9 of them are very essential amino acids, which are normally not made in the body. And some of them are made, but the 9 essential amino acids are the key to the whole story of the protein intake. So that is what you should know how to eat right. Number one, Indian diet is not very non-vegetarian oriented. So protein, getting all your essential amino acids is important, which the body cannot make. Then net protein utilization of the protein you are eating. That is very important. If you are having a net protein utilization of a protein intake which is little poor on the poorer side, you will need more protein compared to what you need. So if you look at the, I would say, all of you would know, egg is the best balanced protein, egg and milk. So egg provides in about 70 to 80 gram, it provides about 10 gram of protein. And your requirement is only about 1 gram. See, some of the Western textbooks write 0.8 gram per kg. ICMR guidelines are saying 1 gram per kg. And some of them, these are the normal, for normal people. Athletes will require a little more. So proteins becomes the keys to the whole story. So you should know what protein you are eating. And milk, although having less protein per 100 gram, 3 to 4 grams per 100 gram, but it is a very balanced protein. So if you know, and if you're a vegetarian, so you should see if you're a non-vegetarian, you're generally having a balanced protein. And if you look at the Western diet, their carbohydrate intake is less. They have more chicken, fish with green vegetables. They eat light in the night also. But somehow with the Indian lifestyle, the things, and that is one of the reasons for the pot belly developing. So first, proteins are to be used as repairing and building blocks, not as energy-giving blocks. Energy-giving blocks carbohydrates can be used, fats can be used. So ratios have to be important. In the Western diet, the proteins are somewhere around 15 to 20%. Indian diet is around 10 to 50% of your total calories. So maybe about 15 to 20% for an athlete. So if you're going to have 30 to 40%, you're going to overload your kidneys. Your protein is also all going to go down the drain. Or if you don't eat sufficient carbohydrates, like I'll take 50% proteins. So it doesn't make sense. Rest of it is all going to go waste, and you're going to spend unnecessary money eating protein powders and wasting a lot of money in which you can use it elsewhere. So that is where how protein supplements come into the picture. But I think anything else you want me to answer?
What I would add is we never emphasize on minimally processed food.
One thing I would like to add, a very important thing for the vegetarians. In a vegetarian diet, you do not get all the amino acids like you get in a non-vegetarian diet. All 9 essential amino acids are available in the non-vegetarian diet. So if you want to eat a vegetarian diet, the Indian diet, you have to have a mix of pulse and cereals. So cereals are deficient in certain amino acids, essential amino acids. Pulse is deficient in another certain amino acid. Methionine is deficient in pulses. But if you eat together in the right amount, you can actually get all your proteins and all your amino acids within the food you are eating.
Tofu has all the essential amino acids. I'm plant-based, so I always speak for the plant. But then having said that, most dietary guidelines across the globe say get all your proteins mostly from plants, and they're moving towards a plant predominant diet. Not that you don't eat meat, but we never emphasize on eating more greens and vegetables as such. And our Indian plates are also deficient in vegetables. You'll be surprised. Even the vegetarian plates are very deficient in vegetables, and they are more towards processed carbohydrates. And that's something, even in the athletic population, it's so important to minimize processed foods. Processed foods are less expensive, meaning very inexpensive. So to have more of minimally processed food, whole carbs, carbs are not bad, of course. Whole carbs and add more vegetables, I would say. I've not even started. Moving on to supplements, Colonel Anup. What are the supplements that are very essential, and what are the supplements that are overhyped?
Yeah, thank you. Good afternoon, ladies and gentlemen. Supplements in sports persons, very essential. Supplements in normal people may not be, for a specific reason. So when we calculate our energy expenditure for a typical sportsman, suppose he's a weightlifter, so he needs maybe 2 grams per kg per day. That is 2 to 2.2. So roughly we keep it at 2. So if he is a 70 kilo weightlifter, he needs 140 grams per protein per day. Now this I'm talking about the bioavailability. The actual consumption may be much higher. Now 140 grams, one egg gives you 7 to 9 grams per day. How many eggs is he going to eat? Now, so it's physically impossible for a top level athlete to consume the amount of proteins, carbs, etc., through natural food. Yes, so natural food first, but the difference in the nutritional aspect is to be made up by supplements. So it is to supplement the natural food. Now, in this case, in this weightlifter, most of the consumption will be focused towards proteins. However, when he is training, we also have to look at his carbohydrate intake, his fluid intake, his micronutrient intake. So this is important. I mean, you cannot get away with supplements usage in elite athletes. Only caveat here is that please make sure that the supplements which you're giving or prescribing to the athletes are certified dope-free. And this has to be done by independent third-party certification. The government or the NADA or the WADA does not do this, right? So supplements in athletes, yes, required. Make sure that they are dope-free. The quality of the supplementation is very important, and the timing of the supplementation is equally important. Thank you.
Thanks, Colonel Anup. I would also say iron. I think many people are iron and vitamin D3 deficient. But I'm also equally, we are seeing mushrooming of the supplement industry, people taking peptide injections, collagens, and, creatine without any reason. And
that's
so on
more
and so
towards the beauty and the cosmetic aspect of it, which we do not deal with too much. But yes, ma'am, that supplements is a rampant industry. And in athletes, we have to be very careful what we prescribe and when we prescribe and how the quality of the supplement is required. And then the other things will come in, whether the athlete is a female, whether the athlete is an elderly, masters, whether the athlete is a child or an adolescent athlete, then vegan athletes, vegetarian athletes. So they will have to be catered for in a separate, especially.
Moving to Dr. Barun, exercise. Are the coaches trained to give proper exercise? Are we seeing athletes being unnecessarily fatigued, exercise overload with no proper guidelines?
Yeah, thank you very much. I am Dr. Barun Sharma. And exercise, because of the lack of time, I will not go into the details things. But the two things, what is important is, one is exercise for the elite athlete side. Another is the exercise for the general population. We are facing both the problem. Overloading, the overtraining syndromes and the injury and the illness associated with the, overindulging into excessive high intensity, high volume exercise is there. And on the other side, there is the, because of the lack of physical activity, lots of non-communicable diseases, that is also there. So both things, sports and exercise, the medicine doctor has to deal with. So regarding, how exercise has to be done, there are so many principles of exercise training, principle of exercise prescription is there, which I will not go into the detail. The point which I want to say that there is 2-3 points. That is, you have to, avoid too much for too soon, especially after too less for too long. And you always had to go, slow so that you can go fast later on. And you can start very low so that you can go high later on. So that's the principle, apart from the exercise, which is a physiological stimulus. And for an adaptation to occur in a physiological stimulation, you have to give proper recovery. And without that, without nutrition, without recovery, nothing will happen. Adaptation will not happen at all. So that's the key point.
I'm glad, yeah, recovery is far too important in an athlete. On that note, we were talking about, when we were doing our research, we were looking at no standard guidelines. Most coaches are not equipped to teach exercises. And ISLM has a relationship with Dr. Barun already. He has come for our conferences, done presentations, webinars. So I was just asking him if we could collaboratively do a train the trainer certification. He said, why not? So Dr. Barun, I'm banking on that, and I'm going to get back to you on that. Sleep, Dr. Sanjay Patil, how important is sleep for an athlete?
Yes. So, ma'am, as you emphasize the 6 pillars of the lifestyle intervention, sleep is, actually sleep is medicine. We say exercise is medicine, just like, so similarly, sleep is medicine. And it is one of the most underrated aspect of our human physiological character that actually that actually directs our performance. So for athletes, for normal population, for everyone, along with nutrition and other aspects, sleep is also very, very important. So just like the nutrition is titrated very tightly, similarly, the coaches, the team, the physio, the experts, they need to also titrate their sleep, particularly for the athletes, for the sports persons. It is not to be ignored, and proper sound sleep should be there. For that, all the psychological support, stress management, everything should be there, just like other pillars of the lifestyle intervention. So, yes, sir.
So yes, sleep has to be addressed, and it's why the athlete is not sleeping. You address the mental health component as well. Colonel Anup, do we have sports medicine clinics? Do they have a specialized psychological support, which is very essential for an athlete?
Yes, ma'am. So we, as part of the sports medicine team, we always have sports psychologists working with us. Even otherwise, if sports psychologists are not available, we always advise the athletes to maintain a sleep diary. The first thing the athlete is asked when he reaches the training field in the morning is, what was your resting heart rate? What was the quality of your sleep? How many hours did you sleep? And do you feel well recovered for the next training session? So this has been part of our drill since a long time. Yes, so if the sports psychologist is available, we tell him or her to look at the sleep aspects. If not, then we do. We also take the help of sleep experts in case we find anything wrong with the sleeping pattern or the sleep timing or the sleep quality, etc., etc. And sleep is very important for recovery, because when you sleep, there is growth hormone secretion. And as we saw in one of the lectures this morning, if there is no growth hormone is not secreted adequately, recovery is not complete. So yes, it is very important.
Thank you. I think we're not going into performance enhancement drug because that's a topic by itself. Just to sum up, I would say, look at every aspect of your athlete, not just exercise, how he eats, how he sleeps, how he recovers, and the mental health, which is very important. Nutrition, I would say, stress on minimally processed, because processed food is very, very inexpensive, buying vegetables or a protein. But then if they are in centers where food is subsidized, or you have a kitchen that supplies, focus more on whole food with lots of greens and vegetables. Those are your natural anti-inflammatory stuff. You don't need any other anti-inflammatory. And look at every aspect of the athlete. We
Can I just
also-
add on, ma'am,
Yeah.
for a second for the proteins? Because proteins are always very expensive. So like sir said, he was right. See, the question is, if an athlete requires about 140 gram of protein, see, I mentioned to a lot of people, I'm a nutritionist also myself, Dara Singh never had extra protein supplements, number one. And he did become a world champion. So if you look at the animal meats, they almost have 20 to 26 gram per 100 gram of protein. You look at soybean, 40 gram. So if you do your maths correct, see, a lot of athletes cannot afford. If somebody if somebody can afford, government is sponsoring, a private agency is sponsoring, supplements are the easier way to do, no harm in it. But if somebody cannot afford the affordability, because most of the athletes, they come from poor backgrounds. So they won't go pressurizing their parents that I need this, only then I can perform. If you do your maths right, you can even come to 150 gram per day.
Yeah, that's very true. We are also in the same dilemma. When we ask people to eat more fruits and vegetables, milk bikis is less expensive than a fruit or a vegetable and a banana. So there we lose the battle. Going on, from ISLM, we do offer a certification course along with the British Society of Lifestyle Medicine. So this is for everybody. It's an award-winning certification course, which is very Indianized. We have changed the content to suit the Indian needs. Our first batch was launched. We were having a course with the Americans, international board, but then we realized we were not producing lifestyle medicine physicians who understood or who could walk the talk. We were doing an MCQ format, and so we changed our format into more in-depth understanding, assignment-based, assessment, and so on and so forth. So we completely have evidence-based practice with lots of modules to read, understand, and write about. A lot of self-reflection going on. So students here and people who want to do the course, please do reach out to us. We are more than happy. It's a 10-month course with mentors helping you out and many people assessing the course. And it's a very structured, we are opening up a second batch very soon. The first batch was very successful. We just started and into third month of it. So this is something that I would like everybody to do because, as I said, lifestyle medicine is an integral part of every specialty. Whatever you do, it has to be an integral part of the specialty. Thank you. Any questions?
Very nice. Thank you so much, Dr. Lakshmi, for moderating it beautifully. I know nutrition is always a very controversial part. I'm just going to give my one observation with my little experience that I have is on the importance of a hydration along with
yes,
that.
Yes.
Hydration, of course, the protein and carbs and micronutrients, all minerals, everything not to be undermined or so. But I have found that our athletes are still not doing proper hydration. And especially we have the weight category sports and endurance sports and all that. So pre-workout, even the water, they still have that same myth which is going on that they have to go and participate in their normal training session without this thing. And the coaches also think that in case they stay thirsty, probably they're going to build up their VO2 max or something. So as I think Dr. Boran and Colonel Anup also was mentioning about it, I find that in your lifestyle, for the geriatric patients also, because I am now in that age group, so even for that also, I think hydration is very important.
Lack of time we
So
could
I'm sorry,
not
just
cover.
an observation to be added.
No. Hydration is very, very important. And being a recreational runner myself, I know hydration is the key. Without hydration, I know most of the things are lost.
We thank the panelists and of course ma'am for moderating, but I just saw that, can you just give us a little bit more insight on that course?
Okay, this is a certification. Yeah, I could do that.
We can do it later, no problems, thank you.
Thanks.
Another very important parameter is iron. We will not get into it.
Yeah.
India, 52% people are anemic.
I said about iron, I did speak about iron, so we couldn't go much into it because of the paucity of time.
Thank you so much for this wonderful insight on lifestyle medicine and all the lifestyle changes that we need to make, a very important aspect of all specialities. I now request Dr. Andrew Linley to kindly come up on stage and felicitate our chairperson and panelists. Dr. Lakshmi Sundar, ma'am. Dr. Sanjay Sood, sir. The rest of the panelists have been felicitated. Kindly, please join in for a group photograph. Thank you so much.
We now move on to an exciting and performance-driven topic, high-altitude training. From physiological adaptations to practical applications in elite sport, this session will explore how altitude can be leveraged to enhance performance while understanding its challenges. It is my privilege to introduce our convener, Dr. Hanjabam Barun Sharma sir, a distinguished expert in sports and exercise physiology. He is associated with the Department of Physiology at the Institute of Medical Sciences, Banaras Hindu University, where he leads work in lifestyle and performance medicine within a clinical and interventional physiology framework. A founding leader in the Indian Society of Sports and Exercise Medicine and a former sports medicine doctor with PSI and NERC, his contributions to research, academics, and policy making have significantly shaped the field in India. We are joined by an excellent panel. First, Lieutenant Colonel Dr. Manoj Yadav, sir, Officer in Charge and Sports Science Faculty at the Army Sports Institute, Pune, bringing rich experience from high performance and military sports environments. Next is Dr. Gagan Kumar, sir, Assistant Professor at AIIMS Patna with expertise in sports medicine, exercise physiology, and cardio-autonomic function. He has served as team doctor for the Indian boxing team at the Commonwealth Games and is an award-winning researcher in clinical physiology. And finally, Dr. Narendra Yadav, sir, Assistant Professor at Mahatma Gandhi Medical College, Jaipur, whose work focuses on the role of sleep in sports performance. A university gold medalist, he has contributed to both research and academic literature in sports medicine. This session promises a comprehensive look at altitude training from physiology to performance translation. Without further delay, I invite Dr. Barun Sharma, sir, to lead the session.
So thank you very much. As the organizing team has informed me, because of the lack of the time, we will not be going into the details of that stuff. So first of all, welcome everyone for this panel discussion on high altitude training. This is one of the most important physiological hacking for optimum performance, because sports and exercise medicine basically deals with DOF-free injury and illness minimization, optimum performance enhancement. So a physiological, one of the physiological technique seems to be the high altitude training, where we want to hack certain physiological principle which may help to enhance the sports performance. But there is also another aspect where we also deal with the performance at the high altitude also. There is 2 points. The first one is the performance at the ground level, at the sea level, by doing that training. Another is the performance at the high altitude, that is also important. So we will focus on the first part here, and I will, call upon all, our expert panelists who are very much expert in, with the practical details. So the first of all, I will call upon Dr. Gagan Kumar Banode. As a physiologist, as a sports and exercise medicine physician, what is your view on the basis of why altitude training is important? What may be the physiological basis? A few points, please.
Thank you so much, Dr. Varun, for the introduction. Good afternoon, everyone. I am Dr. Gagan Kumar Banode. Right now, I'm working in AIIMS Patna. But as you know, we are all trained in sports medicine in NS Patiala. I am the MBBS batchmate of Dr. Varun. Then we were there in Patiala for some time together. And I joined the Indian boxing team as a team doctor. So as you know, we are here for talking about the high altitude training. I was exposed to high altitude training just after completion of my sports medicine. See, I completed my sports medicine in 2011-13, and then straightforward I joined NS Patiala as the medical officer and sports physician. And I was posted in Sai Shilaru, RGHATC. If you have seen Rajiv Gandhi High Altitude Training Center, it is situated in Shilaru, 50 kilometers from Shimla. I was posted there with the Indian women judo team. Jeevan sir was the coach, head coach at that time with other coaches. Sodi sir was there, madam was there. And then if you know our Olympian, Garima Chaudhary was there. So I still remember those days from 2013. We were posted in RGHATC. Pritam Singh Chauhan sir was there as the director, the volleyball coach of Indian women volleyball team. Right now also he is working after retirement with the women volleyball team. So when I was posted over there, I used to attend their training sessions. And if you know, so many world champions has been produced by Jeevan sir. In that judo team, Sushila Rani was there and others were also there. Then later on, Indian weightlifting team also came and joined us, like Mirabai Chanu was there. If you know, she's also an Olympian and world champion. So she was also there. Cyclist came and so many others, walkers, teams came. And then at that time only Jeevan sir requested me to take a session for athletes on high altitude training and what are the benefits of high altitude training. So from a physiological perspective, what do you know about, what do you understand by the high altitude? If you see Shimla, just like in different presentation, it has already been shown. Then what happens at Shimla? Okay, like partial pressure of oxygen comes down. Hypoxic conditions are there. Hypoxia. So naturally you will think, oh, hypoxia is there. It is producing some stress on your body, hypoxia is there, so erythropoietin will be produced. RBC production will increase. It should help in your training. No, it is not that simple. Okay, it has been seen that if you train at high altitude, the aerobic capacity tend to reduce than increasing. If you are staying there for a long period of time, I'm not going into the mountain sickness or adaptation. I'm telling simply the thing that if you assess the aerobic capacity of the athletes after training in the high altitude, it tend to reduce over time. Okay, that's why the concept has changed. What is the new concept we know? Concept is stay low, train high. Concepts of hypoxic chambers. Hypoxic chambers came, isn't it? The developed countries are utilizing it. So they are staying at a low altitude and train at a hypoxic chambers. So basically athletes are exposed to the hypoxic conditions. So these physiological changes will occur. Erythropoietin will be produced, RBC concentration will increase, but at that same time, the negative effects of the high altitude won't be there. Okay, so I just wanted to tell you guys this, the concepts has changed, and some of the physiological, because time constraint, I'm not going to too much detail, but this is from my side. Thank you.
Thank you very much. So the basic point which Dr. Gagan has highlighted is at the high altitude. You know, high altitude means 1,500 meter. If it is more than that, here what is happening is, as he has already highlighted, there is drop in partial pressure of oxygen. 21% oxygen is still there. But because of the hypobaric condition, the presence of the oxygen in your alveoli decreases. Because of that, hypoxia condition arises. And because of the other factors, like for example, hyperventilation as a part of the acclimatization process. So we have to choose only that effect which are beneficial for the body and neglect those effects which are not so beneficial. Like for example, you will not be able to train high at high altitude, so training load will be decreased. If the training load decreases, then what will happen to your training adaptation? So that's why a protocol is very important, where we have to focus on only, what we can get the best. So in a different type of protocol setting in the high altitude, I would like to, request Lieutenant Colonel Manos, Dr. Manos, to highlight on what are the different protocols which are there as a part of the high altitude training, and what are the pros and cons, and what are practical, use of all that.
Thank you, sir. A very good afternoon to all of you. To the outset, as the Dr. Gagan has already mentioned, different kind of protocols. So primarily there are the 3 protocols which are used for the high altitude training. The first one is the live high, train high. Second is the live high, train low. And third one is the live low and the train high. So in the sporting, mostly the athletes are using the live high, train low protocols. But all the 3 protocols has their own pros and cons. So to start with live high, train high. So as the name suggests, the athlete will stay and the training at the high altitude. So the altitude should be more than 1800 meter of altitude, and the duration would be almost 3 to 4 weeks. And the exposure duration will be more than 12 hours. Then only there will be the hypoxic effect, and there will be in turn, there will be change in the RBC volume, in the hemoglobin mass, and which in turn will increase the VO2 max. And later on it will increase the performance. But the pros and cons of this protocol, because the individual is going to stay at the high altitude, so there will be some acute mountain sickness symptoms. That will be the one of the problem. Second would be if the athlete is participating later on in a competition which is going to held in a high altitude, then only there will be a positive effect. Okay. The other negative effect would be like there will be decline in the neuromuscular adaptations, which the athlete has attained during the low altitude training. The second, live high, train low, which is majorly used, the athlete will stay at a high altitude and will come to the normal altitude or the near sea level for training or even for the competition. So this protocol is very useful for the athletes who are participating in the near sea level competitions, like the marathons are being held at like Delhi Marathon, Bombay Marathon, something like that. The third protocol is live low and the train high. It is not very much used because it is only used for the pre-acclimatizations. So all the 3 protocols has their own pros and cons, and the major driving factor is the venue of the competition, whether it is at the sea level or at a high altitude level. Thank you.
Thank you very much. So here we can see that there are different protocols, as sir has already highlighted, what are the pros and cons, and what are things which is more, which is most beneficial, where the adverse effect is minimum. So after knowing the different protocol, we have also to know what are the certain things which an athlete which are going on, which are doing high altitude, what are the things which they have to take care. What are the considerations which we have to take, and what are the preventive measures or any kind of the medical issue or any kind of the, so that the training effect should be maximized, so that we can get the potential out of that. So for that, I will request Major Dr. Narendra Yadav to please highlight on what are the different factors which the athlete should consider, while undergoing a particular type of high altitude training.
Thank you, sir. Good afternoon, everyone. So basically, as we have discussed, if we want an optimal result from the high altitude training, then there should be a balance. It's not in the high altitude. If an athlete is training, then there should be balance between training and recovery, or optimal dose should be there. So there are certain considerations we have to take while inducting the athlete into the high altitude. First and foremost is hypoxia stimulus, which should be given to the athlete for optimal acclimatization. So hypoxia stimulation, basically when the low oxygen, partial pressure of oxygen is there in the blood, then there is a hormone known as HIF, hypoxia inducing factor, 1 alpha, which got released, and it is directly proportional to the amount of hypoxia stimulus. So when this HIF is activated, every adaptation or acclimatization which occurs in the high altitude is because of that HIF. So erythropoiesis, which occurs, increase in red cell mass, it is because of HIF. And as I said, HIF is directly proportional to stimulus of the hypoxia. And the stimulus of the hypoxia depends on the altitude. So if we are training or staying at very low altitude, then the stimulus will be very low. So it will not give that adequate stress to the body for acclimatization or adaptations. But if it is too high, then there it will put extra stress on the body, and it may lead to maladaptations. So as per literature, ideal altitude should be between 2,000 to 3,000 meters. Then second important point to consider is duration of induction or duration of acclimatization. So minimal, they say 3 weeks, but ideal or optimal should be at least 4 weeks of acclimatization or induction. Then third is history of acclimatization or earlier history of induction into the high altitudes. There is a term known as hypoxia priming. So the individuals who trained earlier in the high altitude, so they adapt early. So we can adjust or we can go little vigorously with their training, those who have already undergone the high altitude training first. But those who are new inductee, we should take some time. Otherwise, again, it will put more stress on the body, and the chances of maladaptations will be more. And next important thing is training stimulus. So like we have discussed these different training protocols. Training, because as Gagan sir has said that as we go into the high altitude, there is reduction in the oxygen and there is reduction in the VO2 max. So we are not able to train at that intensity. So intensity of the training is very important. So because of that, we have kept the protocols like live high and train high. So earlier the classical protocol was live high, train high. So in that, the individual was living at the high altitude, and he was training at the high altitudes. So more of the hematological adaptations were there. But over the time, they noticed that it was effective for, we can say, intermediate level of athlete. But for elite athletes, it was increasing the VO2 max, but there was no significant improvement in the performance. So then they studied and they found out that at the high intensity, he's not able to, at the high altitude, he's not able to perform at that intensity which he was performing at the, or which he was practicing at the sea level. So intensity was compromised. So the adaptations which were there in the muscle, they were not optimal. So then there was a protocol introduced, live high and train low. Live high, individual will stay in the high altitude, and then he will come down and train at the low altitude. But again, then there was two ways, either it is artificial or it is in the natural form. So studies found that natural form was always better as compared to artificial in terms of the performance. But then again, there were challenges for high altitude in the natural environment because the stress on the body is not because of the training. There is also known as non-training stress, which we discuss in the morning, under-related causes of the hypoperformance. So additional stress was because of the traveling. Individual has to go up, stay there, then he has to come down, then he has to again go up. So traveling was additionally causing some fatigue. Then they gave a term known as the high-high-low. High-high-low is basically the individual will live in the high altitude, he will train in the high altitude, and for intensity training, they will come down twice or thrice in a week to the lower altitude. So like alternate day, he can come down. So the travel was reduced and the performance or the results were same. So again, for coming down the altitude, to practice the high intensity training, the altitude should be less than 12,050 meters. So that's the level below which he can perform at very high intensity, and his whatever adaptations he had gained because of training can be retained. So training is very important. Next is recovery. In recovery, first of important is nutrition. Nutrition, mostly is micronutrient and macronutrient. So micronutrients are iron, folate and B12. If their level are adequate, then only the erythropoiesis will be adequate. So most important among them is iron. Iron plays an important role in the hemoglobin, but it is also important part of myoglobin, which transports the oxygen in the muscle. Then it is also part of some mitochondrial enzymes. So if the athlete is low in iron, which is we call as the stored iron, which is ferritin form. So insufficiency is for, we can say for the female athlete is less than 35 nanogram per DL, and for male athlete it is less than 50 nanogram for male athletes per DL. So if the individual is low in ferritin or iron, then even if he is training adequately, even if he is at the adequate high altitude, then the adaptations will not take place. It is known as the blunted erythropoiesis. The RBC mass will not increase as per what we are giving him training. So it is very important to do the baseline serum ferritin level, and if the individual is low, we should supplement him before inducting him into the high altitude, and we will also supplement during the training also. And next important thing is macronutrients in form of carbohydrate, protein, and fats. So most important among them is carbohydrate, because as we go in the high altitude, with the hypoxia, most efficient fuel which generate the energy is carbohydrate, because fat and protein, they require more oxygen for the production of energy. So main fuel at the high altitude is carbohydrate. So carbohydrate ingestion is very important when we go to the high altitude. Again, there are chances of weight loss in the high altitude because of two reasons. One, their appetite is reduced. There is a hormone known as leptin. So leptin is proportional to the fat percentage which is there in the body, and it crosses the blood-brain barrier, and it stimulates the centers to give the signal to reduce the appetite. And hypoxia is an independent stimulus for increase in expression of leptin. So expression of leptin increases, it goes in the brain, it reduces the appetite. So the athlete will consume less calories. Second thing is there is increase in BMR of the athletes. It is because of stimulation of thyroid. T3, T4 are increased, secretion of T3, T4 are increased in the high altitude. And because of high altitude and cold, there is also increase in epinephrine and norepinephrine. So basic metabolic rate of the athlete will increase. These two will lead to the calorie deficit, and there are chances if he is not taking the adequate calorie, then he will lose the weight. Initial losing of the weight is because of the fat, but over the time, if the individual stays there, then the weight loss is in form of the muscles. And if muscles are loose, then he will not able to perform at the intensity. So macronutrients are very important, that too carbohydrate. Again, we all know that if we are performing high intensity workout, that carbohydrate is bad fuel. So if anyway the individual is depleted of carbohydrate, he will not able to perform at intensity, and then there are chances that he will not get adequate adaptations. Then next important thing is hydration. As we go in the high altitude, because of high altitude and cold weather, there is decrease in vapor pressure of the air. So there is more difference, vapor pressure difference between the skin and the altitude. So more water will be evaporated from the skin, and as the individual is inducted in the high altitude, there is increase in respiratory rate also. So fluid will also lose in the respiratory form. Third thing is cold-induced diuresis. So because of all these three reasons, he is prone to dehydration. And if adequate care is not taken for dehydration, then there are chances that his performance will affect. As we all know, if the dehydration is more than 2%, then it significantly affects the performance of the athlete. So again, hydration is very important. As a thumb rule, 3 to 5 liters of water should be consumed at high altitude, but again, it should be individualized. If we can measure it, then if we have facilities, then we can go for specific gravity, urine osmolality, and if not, we can go for pre and post weight measurement. If it is more than 2% loss of the weight, then it is because of water loss. Then next is sleep. Sleep is very important for recovery. We are discussing since yesterday. The lecture was there for the sleep. So when we go into the high altitude, there is a cycle of hyperventilation and apnea. It is known as periodic breathing. As we are inducted in the high altitude, there is hyperventilation. Because of there is a washout of CO2. Because of CO2 washout, if it is below, it falls below the apnea level, then there will be sudden stoppage of breathing. If breathing will be stopped, then the individual will wake up. So there will be frequent breaks in the sleep. Second thing is, as we have discussed, because of cold and high altitude, there will be epinephrine and epinephrine and norepinephrine secretion. So sympathetic stimulation will be more. Sympathetic stimulation will be more, so there will be difficulty in initiating also and difficulty in maintaining of the sleep. So because of that, sleep is impaired. So that's why there will be improper recovery. If improper recovery will be there, then there are more chances he will go into overtraining or maladaptations will be there. So for this, initially he should be given adequate time for the rest. As yesterday Dr. Karuna has discussed, there are two types like insomnia and sleep deprivation. So insomnia is when you are given opportunity but you are not sleeping. And sleep deprivation is you are given opportunity but you are not sleeping willingly because of watching YouTube, social media and all. So athletes should be given adequate opportunity or adequate time to sleep or rest. Especially for the initial day when he is inducted, later on he get acclimatized and then he can sync it as per their training program. So these are most important thing. Then next things to consideration is genetics. There always, when we are training at sea level or we are training at the high altitude level, there always genetics which plays important role. There are always responders and non-responders. So we should be not expecting the same results in all the athletes. So although there are few genes which have they say that they are more responding to the high altitude training, that like AC gene than EPAC1 type of gene. But again, these are very detailed. We should keep in mind that all will not respond at that same level, and then their training has to be individualized, and we should not expect the same result. Next is sex difference. We have discussed enough in the female athletes. So there is always a difference when like hemoglobin, increase in hemoglobin mass is definitely more, as per studies, more in the males. There are certain reasons they say. The reason they have given is because of testosterone and increase in erythropoietin. They act in a synergistic manner to increase the RBC production or hemoglobin production. Second thing is males are having baseline more hemoglobin and blood because of menstrual loss in the females. Third thing is, as males are having more muscle mass, when they are training, they are producing more hypoxic drive. So because of that more hypoxic drive, they are adapting better. They are giving better stimulus and they are challenging better as compared to females. And next important is illness or injuries. If an individual is having viral illness or any disease, then at high altitude he is already at the risk of stress. But if he is at the high altitude and ill, then we have to be little bit more slower as compared to the individual who is healthy.
That's a very detailed explanation. Thank you very much. So he has covered comprehensively everything. So not much time is there, but still we can take one or two questions. Please, sir.
Thank you. I have just one question, Mr. Moderator, Dr. Baran, for the August panel, is that in Sports Authority of India, I also, like Gagan, I've been attending at HATC Shilaru and also in Munnar with long distance and medium cyclists also. In my experience, of course, Shilaru was my second home for a good number of years. Like every summer we used to be there for various camps of boxing, judo, and weightlifting even we took also. My question is that we are spending so much of money in Sports Authority of India centers and creating these high simulation altitude chambers, and they started using it. What's the difference that expert panel would like to tell me, that to create high altitude centers or these simulation chambers are good enough to take care of the training of high, low, whatever the protocols that are there? That is my first question. And my second observation is, I think the time has now come where the ISSEM can take the lead in giving concrete guidelines in making the training methodics of sports persons game-wise, specific-wise, because training and recovery, as has been mentioned also, is very important aspect there. And our coaches, even the physicians going along with that, they are not aware of it. Even training methodics also are not over there, with the inputs from the physiology like that you have it over there. This is my observation.
Thank you very much, sir. It was an excellent part. So any of the panelists, if you want to take up the first question, what is the difference between actually going to the altitude and having the hypoxic chamber here? What is the difference and what are the, nuance, what are the things?
Sir, as far as the Safdarjung is concerned, it is at the altitude of 2500 meters, sir, if I'm not wrong. And so the difference between the natural environment and the artificial one, as like the hypoxic chamber. So the artificial one we can establish at any place. It can be very close to, like the logistics support, it can be very close to any airport. So whenever the athlete is going to travel for any competitive the events, so it will be easier for him or her to travel. So the effect of the hypoxia effect will be there, sir. So sir, but sir, certainly there are certain difference because in the chamber we can have the normobaric or the hypobaric, sir. So normally in the artificial we are having the normobaric chamber, we are not having the hypobaric chamber. Whereas in case of the natural environment, it is the hypobaric one, sir. If you go to the natural altitude, sir, it is the hypobaric ones. So there is a difference in the erythropoietin response in the natural environment and in the artificial environment, sir. Second is the logistic issue, sir. Sir, traveling time. And the effect of this erythropoietin, the increase in the hemoglobin mass, RBC, and in turn, increase in the VO2 max will last for a few days only, sir. So we have to consider all these factors, sir.
Yes, sure, sir.
That I have seen athletes using at Sonipat, you see in Patiala, Bangalore, wherever we have created it. They just go for one day, spend an hour over there, you see. And I said, this is wastage of time, you see. We are not using all the principles of high altitude over there.
Absolutely, absolutely.
So that's why it is becoming very confusing, spending so much of money. I mean, of course, both are expensive, creating a high altitude center and the hypoxic chambers also. So
Absolutely.
again, it's very confusing as far as I'm concerned with that.
So again, one of the important things I want to add along with the sir, that the location of the competition is also important. Suppose if it is at the sea level, then in the hypoxic chamber, we can control the environment. Like other ill effects which are due to the environment, like solar radiations, then decrease in water vapor pressure, and dehydration, these can be prevented at the hypoxic chamber. And we can control the environment and the dose also. We can shift the altitude in that. But the initiation of this hypoxic chamber, which I read in the literature, is because of high cost involved in the high altitude training. Because athlete has to go there, he has to stay for 1 month, 2 months, and then he has to come down. But if the training or if the competition is at the high altitude or moderate altitude, then it is always better to go at the altitude and train there. Because if he'll train at the hypoxia but normobaric, then the condition will not simulate at the conditions which are at the high altitude, sir.
So any more questions? Please.
Thank you, Dr. Baran, for the wonderful discussion. So I would like to give a few tips, because I'm working with Randy Wilbur, who is the chief sports physiologist for the USA National Olympic team for the last 35 years. He's the high altitude expert he's been, you may have heard about it, Professor Randy Wilbur. So what they are actually practicing is, rather than using, even though they have the highest technologies, they use their natural high altitude the places to be in their athletes. Every Olympics, these athletes are going there about maybe 6 months, 4 months before, and they will choose the closest high altitude center there. In Paris Olympics, they were at the Alpine. Even in Tokyo, they were selected there. And they have the money, they have the power. Even some athletes are bringing same day morning from that center to the ground. So this is how the USA, people, really implement these practice in their athletes, and how many middle distance and long distance, the medals were taken up over the African people by the last couple of years. So these are like few of the things actually we can think about. So that is where this artificial chamber and also the placing in the natural high place, the take place and this. Thank you very much. Just my idea.
Thank you, thank you.
Add on to what sir said. I don't know, it also, maybe when we were talking with teams, it will be difficult to manage the team in just 1 or 2 chambers. We will not be having 20, 30 chambers. So if you're managing a football team or a hockey team. So, and of course, like you rightly said, we train high or sleep low or train there. My question to the esteemed panelists is, what would be the sweet spot, say, in terms of height? Like, would it be, you mentioned a few heights, so would it be like 2,000 meters, 2,500, 2,300? I mean, of course, we'll keep in mind the acclimatization to whichever country you're going for a competition. But here, rather than going for competition, we're just talking about high altitude training. In India, the concept of high altitude training, basically, let me tell you, with most teams is in hot summer, we go, so there is no periodization for training. It is just to escape the hot summers of the plains. So, so can you just tell us the sweet spot of the height? So I think even the government can look at what is the sweet spot to go for, to have a training camp there.
Sir, as per the recent meta-analysis in the 2023, sir, the sweet spot comes to 1845 to 2445 meter height, sir. So that is the optimal altitude, sir, in which the athlete can be trained, sir. So 1845 to yeah, into 3.3, roughly, 8,000, sir. So 1845 meter to 2445 meters, sir, is the sweet spot. Thank you, sir.
You have to calculate the exposure hours based on the height and also the how many hours that athlete,
Yes,
you know,
sure.
so the minimum is 872 and between 55. So that is one of the things, because otherwise, you know, as he said, like going 1 or 2 days, and also you need to have the long lasting, so you have to, you know, see how these can be, you know, implemented. And also once these athlete expose, once we, you know, get their, you know, optimum levels of their altitude, you know, effect for their body, and we have to have the time frame to utilize this effect. You know, some people go off season and do the altitude training and come back, and after that, no training. So they just go for fun and just because of sake of doing altitude. So those are the areas that I think we have to rectify in this our setup.
Yeah, definitely. That's a very the wonderful topic, and I hope the message is clear that the high altitude has a certain effect, good effect as well as bad effect. We have to select the good effect, what are the physiological effect, and what are the optimal doses are also there. And thank you very much to all the panelists for this wonderful discussion and the wonderful audience also. Thank you very much.
Thank you so much, sir. Now I would like to request Dr. Asela, sir, to kindly grace us on the dais to give the felicitation. I would like to call upon stage Lieutenant Colonel Manoj Yadav, sir, to kindly come and receive their memento. Lieutenant Colonel Dr. Narendra Yadav, sir. I request all the panelists to kindly come for a group photograph.
Translating rehabilitation into performance training, integration of sports medicine and strength and conditioning. This is an area that truly defines modern sports medicine, where recovery is not the end point, but the bridge back to optimal performance is the destination. It is my pleasure to introduce our convener, Major Dr. Amar Singh, sir, sports medicine specialist at Sports Medicine Center, Lucknow. who brings in valuable on-ground experience in managing athletes through the full continuum from injury to performance readiness. We welcome you, sir. Joining him is an accomplished panel. Squadron leader, Dr. Arivarasan, sir, sports medicine specialist at Airmen Training School, Belagavi, with a strong focus on injury prevention during physical training and ACL rehabilitation, along with credentials such as FIFA Diploma in Sports Medicine and ISAC Level 1 Anthropometry. He represents the evolving interface between clinical sports medicine and applied performance. We welcome you, sir. Dr. Badrinath Prathi, globally trained physiotherapist and a doctor of physical therapy degree from the United States of America. His work spans high-performance systems, research, and interdisciplinary sports care. With a keen interest in muscle and tendon injuries, regenerative medicine, and athlete return to play. His experience includes endurance achievements like completing the 10-kilometer ultra trail run, reflects a deep personal and professional commitment to performance. We welcome you, sir. So over to you.
Thank you, Dr. Khyati. The topic is translating rehab into performance training. So, ladies and gentlemen, we promise to be short. We just need 10 minutes of your undivided attention. So, what does the topic mean? Integrating sports medicine and strength and conditioning. Many a times we have seen athletes, they do well in the clinic, but once they go on the ground, they come with reoccurrence of the same injury that they had been rehabilitated for. This is something which is very common, and I think there needs to be bridging of the handover gap between the rehab that is done in the clinic and the rehab which is done on the ground, or the strength and conditioning which is done on the ground. Why should an athlete's rehab fail after 7 to 8 months of rehabilitation? I mean, if there's an athlete who has suffered a ACL reconstruction or an ACL tear, and he has undergone a structured rehab for 7 to 8 months, why should it fail? Is it failure of the graft, or is it really failure of the integration of the rehab team? When we talk about failure of integration, what do we really mean? Dr. Adivasan.
Yeah, thank you. Actually, integration, we all know the Bruckner's model, like where the athlete and the coach remains in the center, and we all the spokes of the wheel, where we integrate our part of contribution to the athlete as a sports medicine physician, as an exercise physiologist, as a physiotherapist, as a nutritionist, as a psychologist, as a masseur, and all this as a biomechanist. So these are all spokes are very important to contribute for the athlete's performance. So once integration happens, it should be streamlined and it should be easy for the athlete to get transformed from rehab to conditioning, then performance, then phase-wise training, etc. So it should be integrated in such a way that the athlete has every component of it for him to put into the game, and supervised and monitored by the coach.
Thank you. To understand the role of each of these specialists during the course of the rehab, we need to understand the phases of the rehab and the roles of each specialty. So, Dr. Badrinath, can you elaborate more on this? Can you throw some light on this, sir?
Good afternoon. Thank you. First of all, I would like to take this opportunity to thank the organizing committee and especially Dr. Harleen also for giving me this opportunity. And 20 years ago, I met Dr. Chandran sir and Dr. Ahuja sir and Dr. Changappa. So yesterday I didn't get the opportunity to say thanks. So today I would like to take opportunity to say thank you to them. And coming to the question, so how I generally do in my practice is the examination is always starts with the medical practice, then in a day-to-day basis is the team sports physio, and the day starts like that. And different phases, it could be divided into a couple of ways. One is the non-weight bearing, low impact to medium impact to the high impact. That is one way I see. And generally, I keep the player till they achieve the muscle capacity. After once the muscle capacity is achieved, then I refer to the SNC with much more freedom. That is one phase. Another way of seeing things is milestone-based progression, especially not time-based, but based on the function. That another way I look into it. Then there is different terminologies used, like, foundational strength, progressive strength, which I'm not big fan of. Generally, I go by the muscle strength. That is, if I take one component as an example, right? And then one more progression dimension that I look into is the planes. One I already said is about the impact point of view: non-weight bearing, partial weight bearing, full weight bearing, low impact, high impact. Then we go accordingly to the running phases. Okay. Then again, we go into the planes, moving from sagittal, then coronal, then rotational, and that too depends upon the type of injury. So these are the different ways that I go about my player, and I try to exploit the non-injured normal parts from the day one. So SNC, the strength and conditioning coach, is always an integral part of our plans, considering the safety and the performance point of view, both ways. I hope I answered the question.
Yes, sir, definitely. You have highlighted the most important considerations that as sports sciences, we should, as people of science, we should follow so that the rehab takes place in a much better fashion. So on the same lines, could you tell us more about the progression of exercises, how they should be from like the closed kinetic chain to the open kinetic chain, and how the exercises should be planned with?
Yeah. Okay. Even before that, like, I would generally, what I insist to my SNCs is to have multiple options for a specific goal, because as a physio, we always once do the assessment, we look into our job is to give the do's and don'ts or restrictions that comes with that assessment. So the job of the SNC coach is to design a plan considering those restrictions, the movement basis or anything. So I always urge my SNCs to have a creative mindset, to have different varieties, different options of exercises. Open chain exercises, closed chain exercises, it all depends on the situation. There is no sequence basis that I follow. It just context and situation and indication basis. Yeah, I use both. We single leg balance, we check single leg squats, many ways. Yeah.
So, what sir has highlighted is, though there is a generalized plan for rehab for each specific injury, there has to be an individualized approach considering the athlete, the anthropometric measurements of the athlete, the specific game that the athlete participates in, etc. As people of science and as sports sciences, we understand the progression of training, we understand the integration of different aspects, but sometimes this doesn't translate when we try to communicate the same to the athlete or the coach. Because for athletes and coaches, absence of pain means the athlete is ready to play. So, Dr. IFSM, could you throw some light on this, please?
Yeah, once athletes get injured, he comes under the umbrella care of orthopedician, sports physician, physiotherapist, etc. So the athlete is at the verge of joining the game soon. So what he will do is, just once the pain is gone, he feels that he is ready to play. But it isn't so. If he is getting treated for an injury, once the injury is not symptomatic, the athlete will be very eager to join the game. But we have to make him understand, and the coach to understand, that there is an invisible injury which is still exists. That is, he has maybe asymptomatic, but his injury has to be healed fully, and he has to get ready for the play. He has to be undergoing the conditioning what he was before the injury. So we should clear him as injury free. Maybe he can resume training by certain tests, and maybe we can tell him that you are not ready, you are cleared for training. Maybe you have to get ready with adequate conditioning so that you can resume your training at the level where he was before injury.
So there's a clear difference between clearance to play and being ready to play. The athlete may feel that he is ready, but unless and until he is given the clearance to play, he should not be participating. Again, when we come towards the end of the rehab phase, there's not just the physical rehab that we have to look into. We also have to look into the mental rehab of the athletes. An athlete who's in the clinic, in a closed environment, in a calm environment, he's trained, he's doing all the activities properly, cannot be directly put into a sports-like environment, because on the ground, there's chaos, there's multiple tasks that you have to handle, there's a lot of overwhelming emotions, and then there's prioritizing the information for an athlete. There's prioritizing information before he takes decisions on the pitch or on the ground. So this forms the part of neurocognitive loading, which also has to be gradual. There has to be return to activity first, and then there has to be return to sports later. Switching from mental fatigue and talking now about physical fatigue. Dr. Badrinath sir, can you tell us more about the workload management of how the workload of the athlete should be managed when he is rehabilitating and towards the end of return to sport?
Yeah, okay, thank you. So a disclaimer, I'm not an exercise physiologist, but I'll try to answer. So I was recently reading a paper of 2024 by Robert Marshall from Germany. So it primarily speaks about considering, in addition to time, duration, we should also consider the component of intensity, accelerations, decelerations, ACWR, HMLD, the so-called high metabolic load aspect with high speed running, and the lactate threshold aspects also, so which is directly related to the injury predictability also. This one point I would like to drive, because it is, I believe it is the first paper published considering the HMLD aspect and the personal endurance performance aspect of the athlete. Till now it is not considered. So that will be my main point to speak about the ACWR. However, this concept can be curated or applied, the principle can be applied in different sports in different ways. For example, in cricket, we can apply the same principle of acute and acute ACWR, acute chronic workload ratio, in terms of calculating the number of deliveries per day, per week, and over a period of month, and number of sessions per week, and the consequent number of days of bowling per week. So all these factors can be considered and curated according to each sport, and we have wonderful results of probably reducing injuries up to 60 to 80% by applying this concept. So acute and chronic workload ratios are really, really important for us. The rate of progressions from session to session or from week to week are also considered. It can vary from 10 to 30%. It depends upon the personal endurance capacity of the player. And we use, as I said yesterday, we use the GPS units, speed gates, even to consider different velocities at which the athlete is hitting during training or during the match. We have baseline data, and we compare every 3 months at least, and whenever they hit the training blocks. So all these things help us objectively to monitor their acute and chronic workload ratios, not just subjective feeling, not by just heart rate or the time duration taken to consider the distance covered. And whether it's a lower limb injury, spine injury, or upper limb injury, we make sure the player hits those baseline data specific to him or her before we clear through RTPs. And regarding the readiness or clearance, one of the things that I would really look into is, in addition to the physical readiness, is the psychological readiness. Psychological readiness. If my player hits that strength-wise, plyometrics-wise, even though he or she is okay, but still if there is some lingering in his mind or her mind, then I would definitely prefer him or her not to play the match. Why I'm saying this, because I personally have seen this, one in the test player and another first-class cricket level player. Both are in the hamstring cases. The heart says to play, but the physical body does not say not to play. They went, in both the cases, they went and played matches, and they both got injured again. One is in the decision-making error, coming back to your neurocognitive training. So there was an error in decision-maker whether to go for the ball. So there was a stuttering fumbleness, and again he got re-injured. And another one, while bowling, they got injured. So the psychological readiness and the neurocognitive training, acute chronic workload ratio, this is how I see into this. And progression into different phases, definitely now I included the high-speed running aspect also, in addition to the low intensity, coming to the high intensity. Muscle point of view, again I would include eccentric in addition to the concentric. Now I have prepared a very short PPT. Can we go back to the first slide? So integration. So even before we are talking about the functional knowledge, domain expertise, it's important to bring professionals from different domains together. So means bringing them together and able to communicate with each other. Only then we can come to some kind of decision. So one way of concept that we follow is, okay, sports medicine team is there. They come to the table with their own domain expertise, with their own solutions, and they prepare an ACWR plan. So here, nutritionist is not changing his or her strategy, nor the SNC, nor the physio. All solutions are considered. This is one way of addressing the problem. Next slide, please. Here I've written athlete ACWR in-season plan. The main problem, one of the main problems that we face is how to convince the coach to apply the principles of ACWR, chronic and acute. So here the SNC job is to sensitize the coach to apply this. So finally we buy in the, one professional will buy in the idea of the other professional. So here the SNC and the physio is buying the idea and concept of the coach, and there will be only one decision. Whereas in the previous slide, there are multiple decisions, okay, applying to the one solution. Here, 2 or 3 professionals from different domains are buying into the one decision for the player. So that is the major difference between the previous slide and this slide. Next slide, please. Next slide, please. So this one concept that we follow as one phase of rehab is a slow resistant training. You can just, it's a video, you can just play it. So rather than a simple starting and ending concentric and eccentric phase of repetition, we have multiple small pauses and do it in a slow manner. This comes into the later stages of rehab. And again, as I said, we progress to the high-speed running. This is the resistance running also, we do it. As we near to the declaring the player fit. So finally, we come to the high-speed running. It can be, so this is, I was training in Palam Air Force ground when I'm preparing for my 100 kilometers race. So on the ground, this is how it look like when I'm on the field. Thank you for your attention.
We come to the end of the panel discussion. The take-away message is an athlete, a rehabilitating athlete to be precise, need not be passed on as a baton from the sports medicine specialist to the physiotherapist to the strength and conditioning. Instead, we need to walk with them throughout the process and end on a high note. Thank you. I'd like to thank the audience for their patient listening and also to the organizing team for having us. Thank you.
Thank you so much, sir. Now I would like to request Dr. Siddharth Unnatan, sir, to kindly come on stage. And everyone has been felicitated, but we'd like to still have a group photograph. Kindly switch on the stage lights. Thank you so much, sir. As we come to the final session of the day, we move into a topic that truly captures the complexity and responsibility of our field, high-stakes medicine, integrating performance, ethics, and decision-making in national teams. At the highest level of sport, clinical decisions are rarely straightforward. They demand not just medical expertise, but ethical clarity, situation awareness, and the courage to make the right call under pressure. It is my honor to introduce our convener, Dr. Kiran Kulkarni, sir, consultant and specialist in sports and exercise medicine, vice president of Indian Society of Sports and Exercise Medicine, chairman of the All India Football Federation Medical Committee, and a FIFA AFC Medical and Doping Control Officer, a leading figure in anti-doping education and football medicine, and a recipient of the National Eminence Award in Anti-Doping Education. We are joined by an outstanding panel. First, Dr. Shubham Ahuja, sir, an attending consultant at BLK Max Super Specialty Hospital with expertise in sports medicine and injury prevention and experience as team doctor for the elite Indian boxing team. With an IOC diploma in sports medicine, he brings valuable insights from high-performance combat sports environment. Next, Dr. Subhashni Devi, senior resident from RIMS Imphal, who has served as team doctor and head of medical support staff for the Indian senior women's football team across major AFC tournaments. Her experience in on-field management, interventional procedures, and rehabilitation, along with multiple academic and sports excellence award, reflects a well-rounded and dynamic career. And finally, Dr. Khyati Vakharia, senior resident at the Sports Injury Center, with an MD, IOC diploma in sports medicine, a former international athlete and national champion in pole vault. She has served as team doctor for the Indian athletics team at major global events, bringing a rare dual perspective of athlete and physician. Without further delay, I invite Dr. Kulkarni Kiran, sir, to kindly lead this session.
Thank you. This session happens to be the last session of this afternoon. This topic would be on, panel discussion would be on high stakes medicine, ethics and decision making in sports. Welcome everyone. Today we are stepping into one of the toughest arenas in sport, not on the field but on the medical rooms. In high stakes moments, team doctors and physios face split second calls. Is the athlete fit to run? What's the safe versus what wins? The pressure from coaches, sponsors, media, and the athletes' own drive can be immense. This puts immense pressure on the sports physician along with the team, but at the center of it all is one non-negotiable: the athlete's health. Both now and 20 years from now on, it will be the same. Ethical lines get blurred when careers, contracts where high-stake money is involved, and championships hang in the balance. Now we are joined by three young national team doctors of football, Dr. Subhashini, boxing, Dr. Shubham, and athletics, Dr. Khyati, to unpack these dilemmas. Now the no textbook answers come into play when they are on the field, just real scenarios and real consequences of what decision they make. Our aim today would be to explore how we make decisions that to protect the player first, not just the player. Let's get into the first question to Dr. Subhashini. In real world scenarios, how do you decide when an athlete is ready for return to sports, especially when there is pressure from coaches, management to get them back quickly?
Thank you, sir, for the question. So, working with the team, for the national team, we have immense pressure from the coach, federation, sometimes from the athlete themselves, so that they want to return back to sports as fast as possible, especially when there is very important match. But our core responsibility is we have to protect athlete career, athlete health. So we don't follow only the time-based criteria, we follow some objective criteria. So criteria-based, we have three criteria. First is the objective criteria. We have to assess the pain level, strength, symmetry, range of motion. Then next is the functional level. Because football is not just running. It has lots of complex movements, sprinting, side-to-side running. So functionally, they have to be fit. Then lastly, psychologically, they have to be ready. If they are not ready, even if they are physically or functionally fit, then there is chance of injury. So these three things we can see, but from my experience, what I have faced some challenging issues, like in case of concussion, which is very common in football, but coaches have less knowledge about concussion. So there was one case, I diagnosed concussion 2 days prior to a very important match. That the importance of the match is if we won the match, we will make a history in Indian football. But concussion is a strict red line. We cannot take risks for the brain health for the athlete. So when I take the decision not to play the player, coach was very dispirited. And even they were telling us, like, in their 10-year experience, they never see an athlete to stop from playing, in this case, in this scenario. But we sit together, we talk about the medical fact and the risks we are taking, the consequences it can be. So after a deep discussion, we sort out. So I make the player to sit on the bench. By the God grace, we won the match and we make history for the Indian football team. And at the same time, we also protect the athlete brain health. Thank you, sir.
That's a good decision. Dr. Shubham, again, have you faced pressure to clear a player earlier than you were comfortable with? How did you handle that without damaging relationships within the team itself?
Yes, so this is something we face on a regular basis in a team scenario, in camps. And the first thing to remember here is as a physician, as a team physician, you are an independent advisor based on your medical knowledge. So this thing has to be clear first of all, in our heads, that our first motive is that athlete's health, and all other purposes, whether sporting or financial, are secondary. Going from there, when you communicate the same to the athlete and the coach, you need to have a firm stance on this, while at the same time appreciating and sharing their sporting needs and commitments. So a simple case which I keep in my head is that if a coach interferes with my decision, I will also interfere with their training regimen and their practice. So if there is a grade 1 injury where the activity-related risk is less, but still I would have preferred to not clear the player. In that case, I would modify the training in combination with the SNC coach. I would keep a track of their warm-up activation with the physiotherapist and their recovery. So what I have felt practically, they might find you a nuisance, but if you keep your stance firm and you show presence, support and commitment in all these phases of training, they will ultimately respect you.
Dr. Shubham, it usually happens like, most of the time, the supporting staff, like the coaches, the managers, they would definitely interfere with the doctor's decision. They cross the lines. But do doctors cross the line, Dr. Subhashini? Not at all.
Not at all.
Like
They
he
only
said,
cross our lines.
even I can change the training, I can ask them to do this, Not at all in football. Good. Dr. Khyati, as a team doctor, you are responsible to the athlete, the team, and the federation. When these interests conflict, how do you prioritize?
So for me, athlete is first. The health of the athlete is the first thing. Now, supposing the athlete is injured, depending on if it is, so I'll share two case scenarios where I have an athlete who is at the Asian Championship, has sprained her ankle during one of her training sessions and has her heats the next day morning. So now I know that it's not such a grave injury, but I know that we have to act fast and we have to make sure that she runs the heats the next day. So whatever said and done, day and night, doesn't matter. So even 12 o'clock in the night, we were in her room doing the things that we needed to do, then making sure that she has enough rest. 8 o'clock in the morning, we're again, seeing her. That is one scenario. Then we have another scenario where there is an athlete who has an ACL tear. Now this is something that you have to put your foot down and say that I am medically not clearing this athlete to play, but then the stakeholders and everything, it's their decision. Medically, this is the thing. Tomorrow, if this is a shot putter and he's going to be throwing the shot put in the pivoting, if he falls in the ring, then that's something that you will have to answer. But from the medical end, I will not clear this athlete. So I think it's about keeping the athlete first, and then as and when you build a relationship with the coaches and with the federation, and then when certain decisions of yours go right, like if you have just like 2-3 decisions that go right for them, then that ease comes in and then they're respecting what you're saying.
Good one. Dr. Subhashini, like when something goes wrong, a misdiagnosis or a serious on-field incident, how should teams handle accountability and good communication? How would you manage that?
Yes, sir. Since we are working under immense pressure, there is chance of making a mistake, even if we give the best effort. But what matters the most is how we respond to it. First, we have to stabilize the situation, ensuring athlete safety, and we can prepare for transportation if it is required. Then after that, everything is settled. What we can do is we should have clear communication with the athlete, with the coaches. There's not be no blame culture. We have to learn from the mistake. So after that, we should have an internal review among the medical team. Where did it went wrong? So whether it was in clinical examination or due to the lack of the investigation finding or because of the time constraint or due to miscommunication. And we have to identify the corrective ways so that we don't make mistake in the future, which will help to strengthen the medical team.
Thank you. Dr. Shubham, back-to-back bouts in boxing and tight schedules, how do you plan their nutrition, rehydration strategies, taking into consideration the weight of the boxer?
So boxing, sir, as you well mentioned, that it is one of the sports where there are bouts on successive days and there are successive weigh-ins as well on the day of the bout. So for that, managing acute weight loss greater than 5% of body mass on a daily basis, it can lead to impaired performance and even inability to lose weight. So for boxers, as soon as they start the camp for a tour, I would always stress them that on the chronic basis, the weight management should be good enough so that the body mass manipulation at acute level is less than 5%. And if the period between successive weigh-ins is more than 24 hours, then we can do the adequate fluid and fluid replenishment. But if the successive weigh-ins are less than 24 hours, then I would advise them to limit their fluid and sodium intake, and along with that, maintain their carbohydrate foods. And on the night before the weigh-in and on the day off, they can engage in active and passive sweating, but it has to be done with caution and ideally in the physician's presence. On the day of the bout, 4 hours before the bout, they can have a carbohydrate-dense meal at around 1 gram per kg of the body weight. And if the athlete has tried this before, carbohydrate and caffeine rinse before, mouth rinse before the bout can be helpful if they are used to it.
I mean, you mean to say that, you know, like along with the sports doctor, coach, as well as your nutritionist, all should be involved in planning this strategy.
Absolutely, sir.
Because we missed by a whisker 100-gram story in the previous
It has
Olympics.
to be a multidisciplinary approach where I can tell the values and how much the amount has to be done, but what are the preferences on that basis, that will be decided by the athlete and the nutritionist, and then the SNC coach can help in the training.
Yeah, Dr. Khyati, we now have GPS load, biomarkers, and injury prediction tools. How much should we rely on data versus clinical judgment on the field?
Sir, it's good to have data, and we do collect data, especially the athletes when they join the national camps. So the assessment is done initially, and then there are subsequent assessments. So the things that are done before, like the injury history, everything, and preventive programs are already put at the first instance. And then we go on monitoring the athletes, and we do rely on the data, but it's not overpowering what you're seeing. If you're seeing something that is not correlating to the data, then there's something that you have to question that. So yes, relying on the data gives you objectivity, it gives you the numbers, but also you cannot, you can't underestimate your own clinical judgment. So I think it's a balance of both.
Yeah, one more last question to Dr. Subhashini. Like you have a football player who is injured, and he also understands, the player understands the risk of injury, but still wants to be in the field with the pressure of the coach or the manager of, or the teammates, mainly in a big tournament. Where do you draw a line as a team doctor?
Sir, regarding the investigation findings.
In a match.
Pardon me your question, sir.
See, as a team doctor, the football player understands, you know, the risk of injury. He understands the risk of injury, he or she, but still wants to be in the game. Okay? Mainly in a big tournament, where do you draw a line as a team doctor?
Yes, sir. Sir, it depends on the type of the injury, and what we have to assess is, if it is like, let's say, grade 1 ATPL injury, where there is risk of re-injury, but we have to assess the pain level of the athlete, and then confidence of the athlete, then the importance of the match. If it is not grade 2, we may consider little bit of, we can give little bit of yes to the athlete, but athlete has to have the confidence to play, At the same time, we should assess the player the whole time during the training, as well, so that they doesn't have aggravation of the pain, aggravation of the symptoms. But if we allow them to play also, we have to be informed that this is the risk, and if you really want to play, you can play, but you should know that at any point of time, if you feel uncomfortable or any symptoms come up, you have to come out. So first thing, we have to communicate with the player very deeply. They have to understand. If they understand, if we talk very nicely to them, like they used to understand, they accept our decision. So the first thing is we have to make a trust among the athlete and the team doctor, so that they trust to our decision, they respect our decision. So this is how we can manage the athlete so that they don't risk themselves to injury.
Yeah, please.
So, sir, as my colleague mentioned, I think for that, I think there should be a clear image in our mind where we stick to the risk assessment, and the risk assessment has to be based on the strategic assessment of risk, which involves health-related risk, activity risk, and then the risk tolerance, where the players and the coaches' input comes into play. So if the health risk regarding the injury, or based on our clinical assessment, if that is high, and then the activity-related risk. So activity-related risk means that metacarpophalangeal joint injury is different for a boxer and different for a footballer. So if the activity-related risk is also high, and these two risks combined are higher than the risk tolerance factors, then you have to draw the line there, in my opinion. And at that point, I feel the player has to be properly informed about this, and ideally, as per the International Federation guidelines, there should be an informed consent taken, because we do everything in good faith. But if a long-term injury happens, or some other long-term consequence leading to injury, who will be responsible? It will be us. And at that time, anything said verbally in good faith might not matter. So informed consent based on knowledge, and preferably communicate the same to the federation as well in mail.
Good. Do you three doctors travel with your, go with your athletes when they are selected for doping control, or you send your physio, or you send your manager?
I personally accompany them, sir, while they are undergoing the dope test.
Thank you. What about Dr. Subhashini and Dr. Khyati?
Yes, sir, we used to accompany the athlete all the time.
So we have a very huge contingent, so the doctor cannot go every time. So the support staff usually goes.
Thank you. Thank you very much, panelists. Due to constraint of time and the closing ceremony now, the role of team doctor is very intricate, where these team doctors have to take split-second decision. And definitely it is not only about the team doctors play on the field, but even before they travel, the managing of their pre-participation screening, their health-related issues, if anybody has, and the previous injuries they are having, everything along with that. The air travel itself is a big, when they travel more than 5 to 6 hours, then definitely jet lag and all those issues. Along with that, team doctors also have to take care of their diet and nutrition too, if they are not accompanied by a nutritionist. Most of the time it happens that the nutritionist doesn't travel with the team. It is a doctor who has to take care of the nutritional aspects. The food in the hotel, they need to go and speak to the chef in the hotel if the proper food is provided, vegetarians versus non-vegetarians. And even after coming back, they need to follow up with their players in long term so that they get back to the field. So the discussion of being a team doctor is never ending, and it will go on. So I thank the panelists, Dr. Shubham, Dr. Subhashini, and Dr. Khyati, for giving their expert answers to the questions I posed. Thank you. Thank you very much.
Thank you so much, sir. Now I would like to invite Dr. Ashok Ahuja, sir, on stage for a group photograph with our panelists and chairperson. Thank you, everyone. With this, I would like to welcome Dr. Harleen Upparnam, our organizing secretary for the conference, to kindly come and give the welcome address for the valedictory ceremony.
A very good evening to one and all. It gives me immense pleasure and a deep sense of fulfillment to welcome you all to the valedictory ceremony of the ISSEMCon 3 2026 conference. Over the past few days, this conference has truly embodied the spirit of collaboration, learning, and innovation in the field of sports and exercise medicine. From insightful keynote lectures to engaging panel discussions, hands-on workshops, which we had 5, and thought-provoking scientific sessions, we have witnessed an extraordinary exchange of knowledge and expertise. We were privileged to host the eminent national and international faculties whose valuable contributions have enriched our understanding and inspired us to strive for excellence in clinical practice, research, and athlete care. We had eminent sports scientists, sports physicians, and sports researchers, sports physios, and we are thankful to one and all. I would like to especially acknowledge the contribution and the collaboration between Indian Society of Sports and Exercise Medicine and Indian Federation of Sports Medicine for a very fruitful and successful collaboration, and for giving Sports Injury Center the opportunity to host this conference. I would also like to acknowledge the enthusiastic participation of all the international faculties, national faculties, and most importantly, the delegates who have come from all over India and whose curiosity, discussions, and active involvement have been the driving force behind the success of this conference. This gathering has not only strengthened the academic perspectives, but also reinforced our shared commitment towards advancing sports medicine in India and globally. As we come to the close of this memorable event, we carry forward new knowledge, meaningful connections, and renewed motivation to elevate the standards of athlete care. Once again, I extend a heartfelt welcome to all of you to this valedictory session. We hope you had a very rewarding and enriching experience. Thank you. Now, I call upon stage the President of Indian Society of Sports and Exercise Medicine, Dr. Dobson, sir.
Good afternoon. At the outset, I'd like to thank all the participants, especially the delegates, for the wonderful success of ISSEMCon 3. We have had 3 elaborate days of one pre-conference workshop and 2 elaborative days on extensive sessions in sports medicine, sports science, human performance, and this has been well received by all the participants. I would like to get some feedbacks from young sports medicine doctors and sports science professionals. What do you think that will need to be improved in the next ISSEMCon? Can we get some hand mics, please? Yeah. Just preferably some junior sports medicine doctors and junior sports science fraternity, just to give a feedback so that we'll be able to improve ourselves next time. Do you feel the sessions has been too overburdening? Do you want to restrict the sessions next time? I think Dr. Sneha, one of my senior students, is there. Yeah. Yes, Dr. Sneha.
Firstly, I would like to thank the entire association. The conference was so enjoyable, such a lovely, especially the workshops. What we really liked, me and my colleagues combined, were the hands-on skills that we got in the workshop that we often, sort of normally we tend to see lectures, but here we actually got to use and get dirty with the things, and it was really good. Loved the workshops, sir. So next time, if we could expand more, give us more topics on hands-on training with the workshop perspective, expanded more than 5, that would be wonderful. But I think this time itself we covered most of the topics, which was amazing. So from the presentation and the conference, lots and lots of topics that were covered. Maybe if we could get some more questions in where we were tight on the schedule, but every single topic, it was sort of like a revision of the Bruckner and Kahn that we had over the last 2 days. So I thank all the speakers and the entire association for giving us that opportunity. So thank you so much, sir.
Yeah. Anybody else? Yeah, Dr. Manish.
Hats off to organizers. I will say in future what should be there, as you asked, your question was, that NMC has got the role that Indian undergraduates, they should have preventive, curative, rehabilitative property when they become MBBS. So syllabus that NMC covers, the only sports medicine is the branch or specialty that covers all main 3 domains, that is preventive, curative, and rehabilitative. And wellness centers are at sub-center level, PHC, but unfortunately they are not trained. They are not able to do the physical, pre-participatory physical examination because they are not expert. So diploma in sports medicine should be there in every medical college at least, so that the PHC and sub-center and most of the population resides of the country that can be taken care of. So NMC should start diploma in every medical college.
Yeah,
so then there will be because nowadays there are only around 200 sports physicians in India. So it's very difficult to convince about sports medicine even to other specialty doctors. Yeah. And Peter Buchner sir told they have got 40 years struggle in Australia, and last year talking at Banaras. So that is the same situation in India. Yeah. It will improve when every medical college is having sport MD specialty and diploma to work at the sub-centers and secondary care centers. That will going to improve the scenario overall in country in a wellness form.
We'll stick to the conference aspect. The policy discussions we already had in elaborate detail about the NMC, what we need to do, and the ecosystem of sports medicine. Anyhow, thank you, well appreciated.
Thank you.
I will be failing in my duty if I don't thank the international collaborations we had, especially the dear friends from Sri Lankan Sports Medicine Association. Dr. Fares is here, Dr. Asela, Dr. Uppal, the president. We also had good participation from Kazakh Sports Medicine, Dr. Berikan Yagner. We had good participation from UK, Dr. Andrews here. We also had from Australia. So we had a decent amount of international collaborations. With this, we plan to take it in a much bigger manner, the field of sports medicine. Yes, ma'am, you want to? I would like to, before that, I would like to have my team over here, Dr. Barun, Dr. Gagan, Dr. Kiran sir, please, in the stage, please. Yeah. Because this is a joint effort. It wouldn't have been possible without this stalwarts here. Yeah. So any queries you can jointly, we'll be able to address. Yes.
Sir,
we also have Dr. Siddharth, who's our former advisor. Come. That's fine, come. He's our advisor. Yes, madam.
Sir, I am associate professor at Bundelkhand Medical College, Sagar. It's a very small place, and I came here. I am non-member of ISSEM, but I am very much interested in this. And I think for the further conference, we should include physiotherapists, especially sport physiotherapists, as well as coaches also. Then we can transfer our views to them also. This is my suggestion for you. And I want to be, I'm just MD Physiology, but I want to be a part of your, what you say, ISSEM. So is it possible? Please.
Absolutely.
Definitely possible, ma'am. Just to, definitely this conference, being sports medicine is a team effort. Basically, the main this thing of sports medicine is one doctor or one physiologist doesn't make a sports medicine team. So it involves everybody who is associated with sports. So we have all the specialities of medical science along with sports physiotherapists, sports scientists, sports dentistry, sports gynecologists now, you know, like, and definitely there has been a wide invitation to all the physiotherapy colleges and the sports physiotherapists too.
Okay, thank you, sir. Thank you. Actually, I am associate professor in general physiology. Actually, I am working at Bundelkhand Medical College, Sagar, MP. So there is nothing about all these things, no sports medicine department. But I was interested, that's why I came here and got a spot registration and attended this wonderful conference. Thank you, sir.
Thank you, everyone. With this, we are going to start the prize distribution ceremony. I would like to request Dr. Professor Dobson Dominic sir to kindly give the late Professor Dr. Arun Kumar De Prize for Best Oral Presentation to Dr. Deepak Godwal. The second late Professor Dr. Arun Kumar De Prize for Best Poster Presentation goes to Dr. Shaharumi Reza. Dr. Khalid is taking on behalf of her. I would now like to request Dr. Barun sir to kindly give the first prize for e-poster to Dr. Pranav. Okay. So the second prize goes to Dr. Navya. And the third prize goes to Dr. Praveen Sharma. Okay. Moving on to quiz. The first prize goes to Dr. Khalid and Dr. Vaishakhan. The second prize goes to Dr. Bharat and Dr. Shivita. And the third prize goes to Dr. Karthik and Dr. Senturan. With this, I would also like to request you, sir, to kindly felicitate our organizing team, Dr. Anil Yadav, sir, Dr. Shushmita Kushwaha, ma'am, Dr. Shushmita Kushwaha, ma'am, Dr. Khyati Vakharia. Dr. Khyati Vakharia. Dr. Shreya Rasania. Dr. Pavneesh Yadav. Dr. Pavneesh Yadav. Dr. Narendra Yadav. Dr. Ashish Yadav. Dr. Adarsh Singh. Dr. Bharat Kanan. Dr. Happy Galawat. Dr. Deepak Godwal. Dr. Khalid. Dr. Arif. Dr. Yash. Miss Angelica. Miss Sakshi. And Miss Shreya. So, Miss Angelica, our sports psychologist, Miss Sakshi, and Miss Shreya, our sports physiotherapist. Miss Jigyasa. Dr. Deepsi Johnson. Dr. Ravindra. Dr. Siju. Dr. Sneha. Dr. Tushant. Dr. Anju and Dr. Kiran.
Dr. Shweta Shri Mohanta.
With this, I would like to announce and give a token of our gratitude to our sponsors and also to the event management team. if you could have a group photograph with the event management team. And with this, we would also like to acknowledge our pharma partners, which includes Qualisys Fukia. We would like to invite them on stage to receive a certificate of appreciation from our side. Next, I would like to request Grand Slam Fitness to come up on stage. Next, we have Hospi Medica International Limited. Kindly come up on stage. Next, we have Aerobe. Aerobe. Next, we have Tanita. Kindly come up on stage. Now I would request Bioconcepts Ortho, the team, to kindly come up. All the participants and delegates are requested to visit the stalls meanwhile. I would now request Texon to come up on stage.
Just tell them to be seated. We'll have a group photograph of all the delegates.
We will have a group photograph immediately after the ceremony. Kindly be seated for that. We request Val to come up on stage. Thank you. With us, we now have Vald on the stage. Next, I would like to invite Delsis Incorporation to kindly come up on stage. Next, we have Farmed Limited. Next, we have Aster. Next, we have MW Enterprises. Finally, we have Intas. So here on stage, we have MW Enterprises, and next will be Intas. Now we have Get Set Events, the event manager for the conference. Kindly come up for a good group photograph. I would also like to request Dr. Shivita to come up on stage for her felicitation. She was with the organizing team. Thank you so much, sir. Now I would request Dr. Khyati to kindly come up on the dais to give a vote of thanks.
As we come to the close of the third ISSEMCon, held under the theme of From Sideline to Spotlight, Evidence, Innovation and Excellence in Sports Medicine, it is my privilege to propose the vote of thanks. I would like to begin by expressing my heartfelt gratitude to the leadership of ISSEM under Dr. Dobson Dominic Sir, President ISSEM, for his visionary guidance, Dr. Hanjamam Barun Sharma Sir, General Secretary, ISSEM, for his tireless efforts in steering this conference to success. The entire team of ISSEM, thank you so much. We extend our sincere thanks to the leadership of IFSM, Indian Federation of Sports Medicine, under Dr. P.S. Chandran sir, Colonel Dr. Rana Chengappa sir, and Dr. Sanjay Sood sir, for their invaluable support and collaboration, which has significantly enriched this scientific gathering. Our deepest appreciation goes out to our esteemed patrons, Dr. Kavita Rani Sharma ma'am, Director, VMMC and Safdarjung Hospital, Dr. Charu Bamba ma'am, Medical Superintendent, VMMC and Safdarjung Hospital, and Dr. Geetika Khanna ma'am, Principal, VMMC and Safdarjung, for their constant encouragement and institutional support, without which this event would not have been possible. I would especially like to acknowledge the dedicated organizing team from Sports Injury Center under the able leadership of Dr. Deepak Joshi sir, Director, Sports Injury Center, alongside the organizing secretary, Dr. Harleen Uppal ma'am, organizing co-secretaries, Dr. Anil sir, Dr. Shushmita ma'am, for this conference has been so meticulously planned and so seamlessly executed. A big thank you to our senior residents and postgraduate students of Sports Injury Center who have worked behind the scenes, ensured the smooth functioning of every session. We are grateful to ICMR for the support. We are grateful to ICMR for the support and sponsorship, and to our pharmaceutical partners for their valuable contribution. Our sincere appreciation also goes out to the event management team, Get Set, for their professionalism and coordination throughout the event. Finally, I would like to thank all the delegates, our senior faculty, and for the engaging discussions and participation, making this conference a vibrant academic platform. With this, we conclude the third International ISSEM Conference. Thank you for being a part of this journey. Thank you, and have a safe journey ahead. Thank you, sir. Can we please gather on the dais for a group photograph?
Without thumbs. Thank you. Without thumbs. Without thumbs. Smile, please. Just. Thank you so much. Thank you. Thank you.
पॉलीसोनोग्राफी का पार्ट हो सारी वो ECG अलग से एक साथ हो गया, हार्ट रेट वेरिएबिलिटी हो गया, ये तो है। वैसे सारी चीज़ें एक साथ तो पॉलीसोनोग्राफी में आ जाएगी। इसमें पर्टिकुलरली दे आर मोर स्पेसिफिक फॉर स्पोर्ट्स पर्सन। अच्छा, कोई बात नहीं सर, वीडियो बना
Thank you. Conference was a huge success. Yes. Thank you.
Pushpa.
नहीं मैम रेडियल है।
अच्छा रेडियल
रेडियल है 4%।
ठीक है अच्छा
Self-management.